All right, good morning, everyone. It is just at 9 a.m., so we're going to go ahead and get started. I know some folks will be rolling in, but that is perfectly fine. Thanks, everyone, for joining us today for the Indiana Cancer Consortium's 2022 annual meeting. Our theme today is Bridging the Divide, Addressing Social and Structural Barriers. I am Mary Robertson. I'm the interim director for the Indiana Cancer Consortium, and I'm so excited to see everyone here today, sadly virtually, but I have all the confidence will be in person very, very soon. So we received great feedback from our annual meeting last year, and I think we'll have another great morning today. So we're going to go ahead and put some information in the chat box if you want to get your attendance for today for some continuing education for CME and CNE. Gage is going ahead and put that in. If you have any problems or troubles, Gage will put this in the chat as well, but please just email admin@indianacancer.org and we will get that all straightened out. So now I'm going to hand it over to Dr. Champion for today's overview and some general housekeeping. Thanks, everyone.
Good morning. I'm delighted to be here. I'm Dr. Vicki Champion and the chair of the ICC Advisory Board. And on behalf of the Indiana Cancer Consortium, I want to thank you for yet another year of collaboration and innovation. Thanks to all of our dedicated membership, our hard work in promoting and sharing the activities of the ICC, we grow and strengthen our voice year after year. We also welcome and thank the Indiana Comprehensive Cancer Control Program at the Indiana State Department of Health. Their financial support that's secured through the Centers for Disease Control and Prevention National Comprehensive Cancer Control Program makes our work at ICC possible. Despite the challenges posed by the ongoing pandemic, it's been a busy year with much to celebrate. The ICC is continually committed to reducing Indiana's cancer burden through coordinated collective actions of its members and the sharing of resources, knowledge, and passion. Today's agenda highlights one of the cross-cutting themes in the Indiana Cancer Control Program, Cancer Health Equity. The national and local speakers here today will take us through innovative efforts tackling social and structural barriers across the continuum of cancer care. We have a few housekeeping notes and then opening remarks from Dr. Christina Box, Indiana State Health Commissioner. Before today's meeting this morning, we hope each of you received an email with all of today's meeting materials. This includes the annual meeting program and contains today's agenda, speakers, biographies, and the new Employer Gold Certified Organization, a reflection of last year's calendar year. We also hope you received a PDF of the Indiana Cancer Control Plan for 21-22. It provides insight into the focus areas of primary prevention, early detection, treatment, and survivorship, which we focus on, as well as recommended strategies and evidence-based recommendations to meet our targets. We want to take a moment to extend our gratitude to our gracious sponsors and give them the sincerest thanks. They include the American Cancer Society, the Indiana University Simon Comprehensive Cancer Center, and the Cancer Support Community of Indiana. You'll also notice our sponsors scrolling through on the screen during the break. We thank every one of them for their support because without them, we wouldn't be able to provide our membership with the incredible free event that we are today. We're grateful for the impressive presenters who will be speaking with us today, and we'll allow a few minutes at the end of each section for Q&A. Please use the Q&A function to share your questions. We will address all questions as time allows. It's my hope that everyone leaves here today a bit more knowledgeable, a bit more informed, and a bit more inspired. Without further ado, let's begin the annual meeting of the Indiana Cancer Consortium with a few quick polling questions. I see the summaries of the votes and thank you for doing this. We're glad to see a variety of folks joining today from many different backgrounds and happy to see what folks are looking forward to. First up, we have Dr. Christina Box to provide our opening remarks.
Thank you so very much and welcome everyone. I am so glad that you could take the time to join us today. I am Chris Box and I am the Indiana State Department of Health Commissioner, and I am honored to kick off this 2022 Indiana Cancer Consortium annual meeting. As most of you know, April is National Cancer Month, and today's meeting marks an important step in our ongoing effort to fight to reduce the burden of cancer in our state. Cancer is the second most common cause of death in the United States following heart disease. Nationally, more than 1.9 million new cancer cases are expected to be diagnosed in 2022. Approximately 2 in 5 Hoosiers now living will eventually develop cancer. According to the Indiana State Cancer Registry, from 2014 to 2018, just over 175,000 Hoosiers were diagnosed with cancer and nearly 83,000 people died from it. This translates to about 45 people dying every day from this disease. Unfortunately, these statistics suggest that nearly all of us will have a personal connection to cancer at some point in our lives. I know I have. My dad had prostate cancer and my mother passed away from her lung cancer. And it's a very difficult thing to deal with, as I know all of you have experienced that. Unfortunately, many of us will have cancer or have a person very close to us that has cancer. The theme of today's meeting is addressing social and structural barriers. At IDOH, we place equity at the center of the work to ensure that every Hoosier, regardless of where they live or work, or their race or ethnicity, or their social economic status, whether they're rural, urban, or suburban, has access to the social and the physical supports needed to promote health from birth through the end of life. It has been said that our zip code plays a greater role than our genetic code in basic health outcomes such as life expectancy, infant mortality, chronic disease, and environmental exposure. While we cannot control what lies in someone's genetic code, we can make every effort to ensure that every Hoosier has equal and equitable opportunity to achieve their best health. Today, we celebrate and thank everyone for all that you do to promote, protect, and improve the health and safety of all Hoosiers. As outlined in the Indiana Cancer Control Plan, each of us in this room plays a unique role in helping to address this burden. Whether you're an individual, an employer, a hospital, a not-for-profit, a school system, or another community stakeholder, or a survivor, by combining our efforts and resources, we can make a larger impact. Understanding the intricacies of disadvantaged and minority populations can help us better address healthcare and cancer support needs in Indiana. To that end, I want to share some data on the cancer disparities that we face in our state. From 2014 to 2018, the cancer incidence rate for African American men was 8.2% greater than the rate for white men in Indiana, while the cancer mortality rate for African American men was 3.3% higher than the rate for white men. Black women also saw a higher mortality rate from cancer than their white counterparts. During that same time frame, the age-adjusted mortality rate for all cancers was significantly higher for our rural counties than for our state as a whole. And during 2020, higher education and income levels correlated with a higher likelihood that women aged 21 to 65 had obtained their pap smear within the past 3 years, that women ages 50 to 74 had a mammogram within the past 2 years, and that adults aged 50 to 75 had a colorectal screening that met the United States Preventative Services Task Force recommendation. During 2020, adults with healthcare coverage or a personal doctor or healthcare provider had significantly higher rates of cancer screening than adults without coverage or without a personal doctor. These are complex issues, and these data just scratch the surface. The Indiana Cancer Consortium is a neutral convener bringing parties from across the state together to address these issues and shared objectives that no one organization can accomplish alone. The Indiana Cancer Control Plan for 2022 and 2023, which was released last January, provides a roadmap for cancer prevention and control in the state of Indiana. It identifies the necessary policies, systems, and environmental change strategies to reduce our state's burden of cancer. Additionally, our hope is that you are inspired to think of creative and innovative ways to get involved or support initiatives to strengthen cancer prevention and control efforts throughout the state and within your respective communities. Although the varying facets of cancer prevention and control, primary prevention, early detection, treatment, and survivorship, everyone can make a difference, whether that involves supporting tobacco-free policies and the HPV vaccine, or promoting and implementing evidence-based screening and interventions. The Indiana Department of Health is a proud founding member of the Indiana Cancer Consortium and a member of the strong cancer prevention and control community represented here today. I'd like to take a moment to recognize the efforts of our nationally recognized cancer programs. The Indiana Breast and Cervical Cancer Program helps females and Indiana residents who are uninsured or underinsured have the ability to access free breast and cervical cancer screenings and diagnostic testing. The Indiana Breast and Cervical Cancer Program is capable of qualifying women diagnosed with breast and cervical cancer for what is called MA12, Indiana Medicaid, which provides comprehensive healthcare coverage during cancer treatment. Year after year, the Indiana Cancer Registry meets the highest standards nationally for data completeness, timeliness, and quality, providing a strong foundation for cancer control and planning and evaluation efforts, and informing numerous cancer prevention and control studies. Finally, the Indiana Comprehensive Cancer Control Program provides technical assistance and support in evidence-based public health practice focused on policy, systems, and environmental change, and partners with the Indiana Cancer Consortium to utilize a collaborative process to pool community resources and to build access to educational resources to reduce the overall burden of cancer in our state. So I thank you again for joining us today. I hope you have an amazing meeting and a blessed week. Thank you for having me.
Thank you, Dr. Box. I know that you have to go to a meeting, so we're very appreciative of your time to open this session. Unfortunately, I didn't have the time to properly introduce Dr. Box. I hope you will take a minute to look at her materials. We are so fortunate in Indiana to have her as a health commissioner. She was appointed in 2017 and has done an amazing job. We thank you from the bottom of our hearts for supporting the Indiana Cancer Consortium and for all you do for the state.
Thanks, Dr. Champion. I'm sorry I jumped the gun there.
No. I could have spent quite a bit of time introducing you, but probably everyone knows you and what you do for us. So thank you so much.
It's such a blessing. Have a blessed day.
Okay, I now want to introduce our first speaker, Amy Jacobs. She is a clinical social worker with HIV/AIDS treatment program at the University of Michigan and an out bisexual woman. She's been involved in LGBTQ and health and mental health advocacy for over 25 years and is a board member of OutCare Health. Amy is also a board member of the Professional Association of Social Workers in HIV/AIDS and is a member of the advisory committee for the advancement of LGBTQ plus health at Michigan Medicine and Southeast Michigan LGBT and HIV Coalition. She's presented on various topics, including LGBTQ and health disparities and cultural competency at several local, state, and national conferences. Amy's passionate about making changes within the healthcare system so that all providers are able to give compassionate and competent care to their LGBTQ plus patients. Amy, the floor is yours. We're fortunate to have you today.
Thank you so much. Hi, everyone. Thank you so much for having me. I'm going to go ahead and share my screen here. All right. Can everybody see my PowerPoint? Thumbs up for me.
Yep.
Thank you. Thank you. All right, so I'm going to go ahead and get right into it because I've got a lot of information to cover in a short period of time. But what I am here to talk about is healthcare access and quality for the LGBTQ plus community. So as Victoria mentioned, I am a board member for OutCare Health, which is a national organization that was started here in Indiana. And the purpose behind OutCare was to provide education to medical providers so that they are able to provide better care to people who are LGBTQ+. So I'm going to go ahead and get started with our outline. Today we're going to cover a few things. We're going to cover shortly sexual orientation and gender identity. We're not going to spend a whole lot of time on this because my guess is quite a few of you are already aware of what these are and what they mean. I'm going to talk a little bit about creating a welcoming environment, so ways to welcome folks who are LGBTQ into your practice. I'm going to talk a little bit about LGBTQ plus health disparities and mental health disparities. I'm going to talk about cultural competency and what that means. And I'm going to talk a little bit about Outcare Health and the resources that Outcare has and can provide to you as providers. So first, we're going to cover sexual orientation and gender identity. So sexual orientation, most of us know what this is, but basically it is how someone characterizes their sexual, emotional, and romantic attraction to other people. So some common words that we use when we're describing sexual orientation are heterosexual or straight. So those are people who are sexually, emotionally, romantically attracted to the opposite gender. Gay is usually described as men who are attracted to other men. Lesbian, women who are attracted to other women. Bisexual folks, people who are attracted to more than one gender. Pansexual folks, people who are attracted to multiple genders or multiple sexes. And then we also have words like questioning, or people who maybe are not quite sure what their sexual identity is or their sexual orientation is. Folks who identify as queer, which is kind of an umbrella term that we use to describe, anyone who's not exclusively heterosexual. Queer is a very common term for younger folks to use today. It's also a term that was used very derogatorily back in the 70s and 80s. So sometimes people who are LGBTQ and a bit older have some feelings around the word queer. And so I'm very careful about where I use that term and who I use that term with sometimes. But we would need to remember that a sexual orientation is an identity, and that is different than what kind of behavior someone is participating in. For example, I have quite a few patients who are men who have sex with men, but don't identify as gay or bisexual. They identify as heterosexual. So their sexual behaviors are different than what their sexual identity is. And so when we're talking with patients or we're talking with clients, it's important to kind of differentiate that. Because someone tells you what their sexual orientation is, it doesn't necessarily define what behaviors they are participating in. In medical documentation, we quite often use the terms MSM, which is men who have sex with men, or WSW, women who have sex with women, rather than using terms like gay or lesbian, although we do still use those terms in medical documentation quite often. We do want to make sure that we are pointing out that heterosexual is a sexual orientation, and it should always be listed as a sexual orientation. Otherwise, it's kind of inferring that heterosexual is the norm or the default orientation, and we want to make sure that that is not the case when we're talking about sexual orientation. Sexual orientation is different than gender identity. So gender identity is how somebody feels about their own gender. It's their internal sense of gender. So common terms for for gender identity are cisgender, which are folks whose gender identity matches the biological sex that they were assigned at birth. So for example, I identify as a woman. I was assigned a female at birth. My mother gave birth to me. The doctor looked, saw that I had a vulva, and said, this is a girl or a female. So I am what's called cisgender. Folks whose gender identity doesn't match the assigned sex that they received at birth are called transgender. So we have people who are transgender women or trans women, who are folks who are assigned male at birth but identify as women. We have transgender men or trans men, and those are folks who were assigned female at birth but identify as men or masculine. And then we have, a lot of things kind of in between and outside of that. So we have folks who identify as non-binary. They don't necessarily identify as male or female. We have people who identify as gender fluid. They kind of move in and out of different genders. People who are gender non-conforming, or people who purposefully are rejecting gender and saying, I'm not male, I'm not female. I don't identify as a gender. Folks who identify as gender queer, which is kind of an umbrella term. folks who identify as pangender, many genders. And so gender identity is kind of all over the map at this point. And people identify as many different genders. We also have people who are intersex, or the more medical term would be differences in sexual development. And those are folks who, when they were born, their genitalia didn't necessarily match male or female, and maybe was somewhere in between. So those folks, we use the term intersex most of the time when we're talking, as lay people, but medical term is normally differences in sexual development. Gender expression is different than gender identity. So gender expression is how you express your gender, right? So we may have people who identify as women, but maybe their gender expression is very masculine. They have very short hair and they wear very masculine clothing, but their gender identity is a woman. So those are a difference, kind of like the difference between orientation and behaviors. There's also a difference between gender identity and gender expression. There are some terms here in the green that we try to avoid using. They are offensive terms, so we do not use those terms anymore, and I'm not going to go through and read through them all. So I like to use the flying gender unicorn as kind of an example to explain gender identity and sexual orientation, because it's a very complicated thing when we think about it. We have somebody's gender identity. So you see this little rainbow here, and it's talking about gender identity, and that's how somebody identifies their gender. Their expression, which is how somebody identifies, or excuse me, how somebody expresses their gender. We have somebody's genitals at birth, how they were assigned at birth. We also have things like hormone levels that kind of define gender with us. So women tend to have more estrogen and progesterone, men tend to have testosterone, but we know that women and men both have all of these hormones, and they're at different levels in different people. We also have chromosomes, right? So we have the XX chromosome as women, XY chromosome as men, but people have XXY chromosomes and XYY chromosomes and part of an X chromosome. So we know that people have differences in their chromosomes as well. We have the gender that they were assigned at birth, which is usually based upon the genitals at birth. And then we have sexual identity, how someone is sexually attracted to someone else. We also have how somebody is physically attracted, emotionally attracted, romantically attracted to people. You may be sexually attracted to someone, but maybe not romantically attracted to them. And so it's really complicated, and somebody can have many identities, many orientations, and quite often those are fluid for people. So they may kind of move through that spectrum. They may identify as lesbian, but then, they're attracted to a man and they're identifying as bisexual or pansexual. And so this can kind of fluctuate throughout people's lives depending on their situation and their environment and all sorts of things. So I want to talk a little bit about creating a welcoming environment. So something that we at OutCare kind of tend to advocate for is introducing yourself right off the bat and setting the stage to be presenting as an LGBTQ friendly provider by just saying what your pronouns are. So when I meet someone, I might say, "Hi, my name's Amy. I use she and her pronouns, or they and them pronouns. How do you like to be addressed?" And ask their pronouns. Pronouns are kind of a politically charged thing right now because there's a lot of people trying to pass many laws prohibiting trans folks from living their lives, basically. And so sometimes people are going to give you pushback when you talk about pronouns, but everyone has a pronoun and everyone wants to be called their correct pronoun. If you identified as a man and used he, him pronouns and someone referred you to she and her all the time, you probably wouldn't like it. And someone who is trans who uses pronouns when you're using the wrong pronouns for them, they don't appreciate it either. So getting that out there, you're presenting yourself as a friendly provider, and you're also giving them an opportunity to let you know who they are. We collect things like people's names. So we usually ask people their names that they were, that are on their birth certificate, as well as the name that they use. So some people use different names. That's true for everyone, right? Quite a few people go by their middle name instead of their first name. But also people who are trans may go by a completely different name than what is on their birth certificate. We ask their sex assigned at birth because those are things we need to know when we're providing medical care to someone. We ask their gender identity, we ask their sexual orientation, their pronouns, and we also respect sometimes that people may not be totally sure what their identifications are at this time. They may never have been asked that before and they may not know, or they may be in a stage where they're kind of confused about it and they're not sure, and those are all okay. But asking people about it does set the stage for creating an environment where people feel comfortable talking to you about it. I mentioned the pronouns a little bit. We see these listed after people's names quite often. So as you can see on my name here, it says Amy Jacobs, LMSW, she, her, hers. Those are the pronouns that I tend to use. Your pronouns are your subjective, objective, and possessive. So like as a feminine person, it's she, her, hers. As a masculine person, he, him, his. And then there's gender neutral terms that people use. They, them, theirs is usually the most common, but people use other things like Z and Zim, and there's all sorts of pronouns that people use. And not only LGBTQ folks use these gender neutral pronouns, quite a few heterosexual and cisgendered folks use them too. It's kind of showing their solidarity for the community. We do not say preferred pronouns when we talk about pronouns because they're not our preferred pronouns, they are our pronouns. So just like we don't say what's their sexual preference when we talk about orientation, these things aren't preferences, they are who these people are. And so we don't use preferred when we're talking about pronouns or sexual orientation or gender identity. So when we're asking questions to folks about their gender identity and their sex, we are asking and giving lots of options. So on forms or when you're doing an assessment with someone, we're asking about their sex assigned at birth. So they may have been they may have been assigned male, female, they may have been assigned intersex or DSD, they may have been assigned something else, and maybe they prefer not to disclose to you, and that's okay too. We ask about gender identity. We always list, the cisgender, man, woman, non-binary, genderqueer. We do want to make sure that we have that other option and that prefer not to disclose option to give people the opportunity to opt out of that if they don't want to talk about that. Depending on what you are providing for a patient or a client, you may not need to know some of this information. If you're a physician and you're providing medical treatment to someone, their sex assigned at birth is important. But if you are the clerk in the front of an office, that may not be as important for you to know. So sexual orientation, when we're asking about that, we're listing all of these options. We are going to always list heterosexual or straight, like I said, to kind of show that that is not the norm or the default, but it is an option because it is a sexual orientation. And then we give people options like lesbian, gay, bisexual, pansexual, asexual. Those are the most common. For people who don't know what asexual is, that's folks who don't have a sexual attraction to really anyone necessarily. And then other people identify something else that's not listed here, and we give them an opportunity by listing other. So when we talk about inclusivity for LGBTQ folks, we are talking about, having this information out there in our programs, in our clinics, in our waiting rooms, using terms that our patients are using to describe themselves. These common subgroups like trans and non-binary and genderqueer, knowing what these words mean, two-spirited, agender, people who don't identify a gender. There's many, many words. There was a slide that was listed of all these different terms that I took out because we don't have time to go through all of them, but there are easy ways to find these online. There's lists of different sexual orientations and different gender identities that you can find online that have definitions. But the easiest way is when you ask someone what their gender identity or their sexual orientation is, and they tell you and you're not sure what that is to ask them. It's okay to ask questions and have people provide this information to you. That's the best way to know how someone identifies. And people use these terms differently sometimes. What is genderqueer to one person may be something different to somebody else. So asking people what they mean is an important way to gather the correct information on them. So stigma and discrimination is very much still a thing. It's very real for folks who identify as LGBTQ. Stigma and discrimination can be interpersonal between, individuals. It can be institutional, like healthcare systems. It can be within a community and a society, and it can be within policy contexts, like we're seeing going on with trans women participating in women's sports right now, or trans folks going to specific bathrooms, and laws and policies that are being passed around these things. It can happen in education, it can happen in housing, it can happen in healthcare, it can happen in the law and the military. It can happen from your peers, your coworkers, your family, your romantic partners. Terms that we hear is, homophobia, but there's also things like lesphobia, biphobia, transphobia. And then there's the other terms, which is the isms like heterosexism, cisism, classism, racism. All of these things fit into discrimination against groups of people who are minorities in our society. The more diversity and the more intersectionality someone has, so meaning the more identities that they hold that are minority identities, the more often that they experience discrimination and stigma in their life. And discrimination and stigma, we know, lead to health conditions, mental health conditions, depression, anxiety. And we know that depression, anxiety, mental health conditions, quite often people turn to unhealthy coping mechanisms, which can turn into medical issues. And so these things, the discrimination, the stigma that people experience is important across the board because it affects every aspect of their life. Discrimination can look like a macroaggression, it can look like a microaggression. The difference between those are macroaggressions are things that are overtly discrimination, large scale, like really ugly terms that people use, these policies that are happening. Backlash against trans people right now seems to be running rampant in the country. Whereas microaggressions are smaller things. They're usually kind of like assumptions that are made about people, or snubs or insults that maybe are not even necessarily on purpose. Those can be very unintentional, but they're still harmful. Microaggressions, there's whole trainings on microaggressions and how to avoid microaggressions when dealing with folks who are LGBTQ. So microaggressions could be things like assuming someone's gender, assuming someone's sexual orientation, asking somebody simply, are you married? Do you have a wife? Do you have a husband? Assuming that they are heterosexual and they may have a wife or a husband. Folks who are LGBTQ are experiencing microaggressions all of the time. This is 50%. I would say that's probably much higher than that. I would say it's probably 100%. People are experiencing these things in their life on a day-to-day basis. Like those macroaggressions I mentioned can be like very derogatory words. But like I mentioned, microaggressions can be just like heteronormativity, assuming everyone is heterosexual, assuming everyone is cisgendered, talking about things like, asking people about their genitals when they're trans. We don't ask people about their genitals when they're cisgender. Why do we ask people who are trans about their genitals? Kind of disapproval, or talking about what's your real gender, what's your real sex, using the term preferred. Making those assumptions, or making comments like, oh, you're not a typical lesbian, or oh, I never would have guessed you were a lesbian. Those are microaggressions. These are microaggressions. These are things that these folks heard from people in their lifetime. They might be kind of hard for folks to read, but things like, how do you even have sex? Or calling someone that gay kid, or saying only girls have long nails when someone who's, expressing themselves in a masculine way has long nails or painted fingernails. Ways to advocate for folks is using people's identities and using people's pronouns properly. If you're a member of the LGBT community yourself, quite often folks who identify as LGBTQ who are providers are open and out about their gender identity and their sexual orientation for several reasons. I'm very open and out about my sexual orientation for lots of reasons. One being, I know that some folks are more comfortable with an LGBTQ provider when they're a member of the community. They just feel like someone's going to understand them a little bit better. Also, it's great to have good role models, right? So somebody sees you in a position as a physician or as a mental health provider, you're out as being LGBTQ plus, and it's nice to have those good role models, right? So you can get places, you can be successful, you can be someone who people look up to. It also builds that rapport with someone. So, you have some commonalities, you understand some things, you may understand more so that people experience these discriminations. And so it's, if you're comfortable, it may be appropriate to share that information with a client or a patient if it's going to help them, right? We always remember that whenever we're sharing information about ourselves, it's to help our client and our patient, not to help ourselves, although quite often these things do help ourselves as well. For me, it's much easier to live my life being an out person so that people know than having to, disclose this to people on a regular basis all the time, even though as LGBTQ folks, we are always kind of coming out. But for me, it's part of who I am. It's my identity. I like to live my life as a, real person and be honest about who I am. And so for me, it's just easier to do that. And I do it for lots of reasons. Some folks may not feel safe doing that. If you're in an organization that maybe isn't super gay friendly or queer friendly, you may not feel comfortable being out about your sexual orientation or your gender identity as a provider, and that's also okay. It's not your job necessarily to do that, but if you're able to do that, I think it's really helpful to people in general to be out. So the visibility is being out, like I mentioned, but also just the competence and the visibility of being a LGBTQ plus accepting and celebrating program. So having posters in your waiting room or having pamphlets in your waiting room, having this information on your intake forms, listing all the options, not just male, female, other, putting non-discrimination policies in place and then putting them in visible places for patients and staff to see. Having those brochures, having gender neutral bathrooms can be so important. Just having, a bathroom that's marked as gender neutral allows folks to feel comfortable going to the bathroom. The bathroom is a very scary place for people who are trans. And so having a bathroom that's gender neutral can mean the world to them. Asking patients about these things, asking them about their sex assigned at birth, their gender identity, their sexual orientation, asking them about their sexual health, asking them about coming out and how that went for them, asking them about family support, asking about body parts and sexual activity, not assuming what people are doing, and asking about STIs, but also asking about all these other things, pregnancy plans, social isolation, victimization. Post-patient care, like care that we provide after we see a patient, are things like using the correct pronouns when we talk about our patients, suggesting parents be supportive of their LGBTQ kids, and then resources. I know I'm going through this and I'm spending more time than I need to because I'm running out of time here, but let's talk about a little bit about prevalence and stigma. And I'm going to skip this, but basically about 4 to 10% of the population identify as LGBTQ, and that's increasing as younger kids get older. The younger kids, when they are polled, there's much higher percentages of different sexual orientations and different gender identities. Marginalization, discrimination, people are experiencing those microaggressions, macroaggressions all the time. 20% of people suffer discrimination in healthcare environments. There's lots of exposure. People discriminate and people work in healthcare. So people run into that when they go and get their healthcare. But healthcare should be a safe place for people, and that's the whole point. Cancers, we're talking about cancers today. At least 7 types of cancers disproportionately affect people who are LGBTQ. So anal cancer, breast cancer, cervical cancer, colorectal cancer, lung cancer, prostate cancer, and uterine cancer disproportionately affect folks who are LGBTQ. There's lots of reasons for that. Like I mentioned that, the stress, the discrimination, the stigma leads to mental health issues, which leads to coping mechanisms that may not be the most healthy. Folks who are LGBTQ plus smoke more often. They have more substance use disorder issues. And so they're using coping skills that maybe are not the healthiest. They may be using food as a coping mechanism. So these can be 2 to 4 times higher in the populations, in LGBTQ populations when we're talking about depression and anxiety. Lots of mood disorders that we're seeing. Implicit and explicit biases. I'm actually going to go ahead and skip this. There's important information, but we're going to skip it because I want to get to the cultural competency part. So what is cultural competency? It is having the awareness and knowledge of how cultural factors affect health. So I just mentioned a lot of things, right? So how does being LGBTQ plus affect someone's health? In lots and lots of ways. But to be culturally competent, the Joint Commission says that you need to meet these 5 criteria for LGBTQ plus competence. It's creating a welcoming environment for LGBTQ folks, which we talked about. It's facilitating disclosure of sexual orientation and gender identity, which by asking those questions, you are facilitating disclosure. It's providing appropriate care and feeling like you're able to provide appropriate care. And sometimes that means that you go out and you get more education, and that's great. And that's what you should be doing. And education should be ongoing because things change with time. Avoiding assumptions about people's sexual orientation and gender identity, and providing information and guidance that are specific to healthcare issues that are facing LGBTQ folks. So real quick, I want to talk a little bit about OutCare Health. That's the agency that I'm representing today. OutCareHealth.org is our website, and there's tons of information on our website. I mentioned that it was put in place to provide education to healthcare providers, but now we do much, much more than that. It is a 501c3 nonprofit organization. The main website has information. One of the biggest things that we do is the OutCare list, or the Out list, which is for providers who are LGBTQ competent. They can list themselves on our list so that patients can go and search. I need a cancer doctor in Indiana. Who can I go and find that I know is going to be LGBTQ competent? They can go on our list and find someone. Our information's in all 50 states. We have over 2,500, it's closer to 2,800 providers now on our out list. There's over 100,000 materials that we've distributed to people over the years of OutCare being a program. There's resources on our website. We have over 500 resources across all the states that you can go and look at your state and pull it up, and it's going to have organizations and programs that are LGBTQ plus friendly. If you go on there and it's missing something, like your program's not on there, then you can email us and we'll add you. We have provider resources, so we have information from all of these different organizations on there for specifically for healthcare and mental health providers. There's trainings like this that we provide for folks that make people, 50% more competent to provide care when they're done with them. It makes people feel more prepared. It changes people's attitudes about LGBTQ folks. It increases knowledge. We also have mentorship programs. We have academic research happening. We have Out Talk, which is a free webinar series that we provide. We have outreach. We have outposts. There's all sorts of information on our website. Please, if you are an LGBTQ plus competent provider, add yourself to our OutCare out list by going to outcarehealth.org/join. We have a newsletter. We have, if you want to give us feedback, if you want to donate to us, please do. We also have a gala coming up in June, a fundraiser that's happening. You can get information on our website at /gala. Thank you. I went through those ending very quickly, and I apologize for going so quick, but I will stay around for a little bit to get questions if people have some questions.
No, thank you so much, Amy. I know I'm laughing because I know we asked you to pack so much in a small time frame, but I think you did an absolutely fantastic job.
Thank you.
And I'm sure we've already had requests to share your presentation. So if that's all right with you, then we'd be happy to distribute it to folks after. We do have one question in the chat for now. It says, do you do any screening of providers to confirm that they're LGBTQ plus competent, or is it just self-declaration?
So eventually we would like to do a kind of screening. The way that we kind of somewhat do this at this point is we have what does he call it? When you go through our cultural competency training, we mark that on your listing so that it's like, I don't know, people have like post like plus, like their listing is, oh goodness, what's the word I'm thinking of? I can't think of the word, but it's self-reported. But then if you go through like cultural competency training and provide information to us on that, you get like boosted basically as somebody that we have kind of provided training to. Any other questions? Yes, preferred provider. Thank you, Deborah. I was having a brain fart there. I couldn't think of the word.
Awesome. I don't see any more in the chat
Okay.
or in the Q&A function, but please, if anyone has any more questions, please put it in the Q&A function. I think Amy has a couple more minutes she could stick around for, but again, my sincerest thank you. It was such a great informative presentation, and I'm so glad that you could join us today. So thank you so much, Amy.
Thank you.
Now I'm going to go ahead and hand it over to Erica, who's going to introduce our keynote speaker for today.
Yes, thank you, Mary. Can you hear me okay?
Yes, you sound great.
Okay, perfect. Hi, everyone. My name is Erica Pedroza, and I'm with the Indiana Minority Health Coalition. I'm also a board member of the ICC. It is my pleasure to welcome and introduce today's keynote speaker, Dr. Jacqueline Orr. Dr. Orr, Program Officer, joined the Research, Learning, and Evaluation team of the Robert Wood Johnson Foundation in 2019. As a strategic liaison to RWJS efforts to transform health and healthcare systems, she draws upon her extensive skills in physician practice management, medical education, healthcare delivery, public health, and health disparities research. Dr. Orr has previously served as a patient experience data fellow with Penn Medicine in Philadelphia, a health disparities intern with AmeriHealth Caritas in Philadelphia, and an administrative intern with the Institute for Diversity and Health Equity, an affiliate of the American Hospital Association. Dr. Orr was Executive Director for Long-Term Acute Care Hospital Physician Practices with Select Medical and Director of Practice Management for Penn Medicine Princeton House Behavioral Health. She also held management and fellowship positions with medical centers, hospitals, and healthcare systems in Mechanicsburg, Pennsylvania, Brooklyn, New York, St. Louis, and Chicago. Dr. Orr earned her doctorate in public health and health policy and social justice from Drexel University, Philadelphia, a master's degree in health administration from St. Louis University, and a BS in environmental chemistry from Xavier University of Louisiana. She is a Detroit native who now calls Philadelphia home. It is my pleasure to introduce our keynote speaker, Dr. Jacqueline Orr. Now, to tell us more about this important work, Dr. Orr.
Erica, thank you so much. I appreciate the warm welcome. Good morning, everybody. Again, my name is Jackie Orr. I'm going to take a few minutes to share my screen and our slides for today. I am grateful to be here. I want to thank Mary and the ICC team for this opportunity. I want to say, as Erica mentioned, my screen is blacked out. Okay, here we go. Erica mentioned I'm originally from Detroit, Michigan. I do have connections and a storied history with Indiana. Many Octobers at Circle City Classic with my marching band in high school, as well as summers with the Black Expo. I spent a summer in Crown Point, Indiana, working with Susan Nordstrom Lopez, actually at St. Anthony's Medical Center, as well as working for Ascension Health, which is the the parent company of St. Vincent's in Indianapolis. I wanted to dedicate this actually to a former mentor, Dr. Subhash Basu. I had an opportunity to do summer research with him at the University of Notre Dame and recently found out that he passed away in November of 2021. So I want to dedicate this to him. I'm grateful for his opportunity to give me bench experience in a biochemistry lab when I was trying to figure out what I wanted to do with my life. So With that, I wanted to start. The title of my presentation is It's All Connected. And this is with the understanding that the ICC, you all are doing the work. Your approach to core activities, boards, and committees, in my opinion, is amazing. This is really an opportunity for us to share what the Robert Wood Johnson Foundation is doing and where we're trying to go as a field, and hopefully we can do this all together. So just to give you an idea about the Robert Wood Johnson Foundation, we are the largest philanthropy that's dedicated solely to health. We are officially this year 50 years old. We were founded in 1972, and we've worked to improve health and healthcare in the United States since 1972. So I wanted to get an idea of what people thought. So within the chat, I would like for you to add a +1 or a that's me if you agree with these words that I'm about to use that are related to health. So we'll start with education. Anybody think that that's tied to health? How about housing? The child tax credit, paid leave, clean water, childcare, healthcare. How about a living wage? And then racism. So I think we got a few responses in the chat. Yes to all, exactly. So this is the same way that we think about health. So the foundation actually defines health very broadly. And so in partnership with others, we're working to develop a culture of health that's actually rooted in equity, that provides every individual with a fair and just opportunity for health and well-being, no matter who they are, where they live, or how much money they have. So in short, we want optimal health outcomes for everyone. And so our vision really comes alive in what we call the Culture of Health Prize. And the Culture of Health Prize elevates the compelling stories of places where residents are working together to transform education, jobs, transportation, housing, and more so better health that flourishes for all. And I wanted to mention there were finalists from Indiana in the past couple years. Scott County, Indiana in 2013 was a finalist for this prize, and then Fishers in Indiana in 2019 more recently. So next, I'm going to actually share a video with you all that's about 5 minutes to give you an idea of our Culture of Health Prize. And let me know if you can hear this.
10 communities.
Uh-oh.
10 stories
Sorry about
of
that.
hope, inclusion, and inspiration for a shared vision of better health flourishing everywhere for everyone. By elevating community voice.
Oh, apologies. I'm trying to check the chat to make sure. Okay, I wanted to make sure you guys could hear it.
To
Here we
drive
go.
lasting change by addressing systemic racism to shape a better future, and by building equitable communities to create opportunity for all.
Our workforce development program creates a win-win for the entire community.
Everything that you need to thrive is easily accessible to everybody.
The phrase takes a village, takes a community really plays out here in Addison.
Inequities are not just created by mistake. They're created by institutions.
We want everybody, including people of color and low-income people, to participate in the decision-making.
We are a place where community leads and leaders follow.
We envision a liberated Lakota nation, and the starting point for all of our journeys has to be healing from the vestiges of colonialism that still bind our people to traumas.
As the next step towards our liberation, our school is number one. I think about the future and how education is going to be playing such a huge role.
The mission is to foster an equitable local food system that restores the health of the community, the economy, and the ecosystem.
It provides an education space for all ages to better understand connection to the land and the food we eat.
We like to say we are data informed and people driven.
We value education, we value cultural diversity and inclusion, and those are things that really resonate with many people.
Our residents are all willing to rally together to make change.
I want people to see that we are a community on the go, that we're rising and that we're developing, and that we're not satisfied with the status quo.
One word we always come back to is access. We're talking about access to food, education, employment, affordable housing, information.
Diversity is what makes National City beautiful.
It's a very close-knit Hispanic and Filipino community.
As the first Latina mayor of National City, I will not be the last. Making sure that these two hands bring up two more, and those two hands bring up two more, and those two hands bring up more.
Systemic racism in Alaska is really profound. Reclaiming those pieces of our culture and our language is part of our healing.
Sovereignty is important to us because it's one of our basic fundamental human rights.
Chitlin embodies resilience and strength.
How do we address structural racism that perpetuates, sometimes unintentionally, inequities for some of our residents?
Racism is a public health crisis, and we need to be aware of what we've done in our past and we continue to do.
Founded by immigrants and refugees, Worcester has been a wonderful city that's been welcoming immigrants from all over the world.
I am very proud of what is happening here in Palm Beach County. Organizations are asking, how do we make a shift and have residents lead?
And we have a community of residents who are showing leadership. It means that we're not just looking at healthcare, we're looking at health. The 10 Culture of Health Prize communities for 2020 and 2021 are turning this vision of healthier people, families, and places into action.
So again, those are our 2020 and 2021 Culture of Health Prize winners. I still get chills every time I watch the video. It's pretty cool, but I just wanted to use some of the quotes from the video to really tell the story of where the foundation is heading with our work. So in Addison, they mentioned it takes a village, it takes a community. This isn't just about a foundation. This isn't just about one single community. Also in Rocky Mount, they mentioned inequities are not just created by mistakes, they are created by institutions. Again, in Rocky Mount, we're a place where community leads and leaders actually follow. Alamosa County, the mission is to foster an equitable local food system that restores the health of the community, the economy, and the ecosystem. We are data informed and people driven. That's one of my favorites because I'm one of the data geeks. And that was from Howard County, Maryland. In National City, they said diversity is what makes National City beautiful. The Chickaloon Native Village mentioned that systemic racism in Alaska is really profound. Reclaiming those pieces of our culture and our language is part of our healing. In Worcester, Massachusetts, they mentioned racism is a public health crisis and we need to be aware of what we've done in our past and what we continue to do. And then in Palm Beach County, they mentioned how do we make a shift and let the residents lead? And so all of these quotes really speak to what these communities have been able to identify and address to advance health equity within their local communities. And so the approach for the foundation has been really evolving over time. And many of those quotes speak to where we're also trying to focus within diverse communities, where a data-driven approach can actually help to address these inequities and racism that is led by the community members. So next, I wanted to talk about cancer and the social determinants of health. So at Robert Wood Johnson Foundation, we recognize that every community is different, and they have their own unique health challenges and needs, and that low income and also communities of color face disproportionate cancer risk. And cancer is a disease that really can affect everyone, but it doesn't affect everyone equally. We know that cancer is a process, and over a lifetime, genetic and environmental factors collectively conspire to destabilize normal cellular processes, sometimes resulting in cancer. However, while cancer may be a process occurring over a lifetime, centuries of institutional and systemic racism have really created the conditions for disparity in cancer risk to not only persist, but to thrive. So here's what we know about cancer and how it's affected by racism and the social determinants of health. More than 40% of cancer cases diagnosed in 2014 in the US were caused by potentially avoidable or modifiable factors. So we're talking about tobacco use, obesity, alcohol, diet, cancer-causing pathogens, and physical activity. And I think it's also important here to give some insight about the evolution of social determinants of health, right? So this has really been a movement from research or theory to practice. And so in the 1990s, there wasn't much discussion outside of research circles. And Dr. Nancy Krieger, while she was at Harvard, and there were a few other articles as well. So Dr. Krieger's article is one of the main articles that talk about social determinants in the 90s. And then there started to be this new wave of social epidemiology that started to brew. And we really shifted from a web of causation to the eco-social framework. And the use of these metaphors, I think, in this space was also discussed a lot. And while they cause us to experience one concept in terms of another, they can also hinder understanding. But without the metaphors, we really can't draw these connections, right? So it also has to be noted that the social determinants also work like a system. So they're both independent and joint effects that can actually occur. And another point of view, because I am a hip hop baby, I like to bring the stories, plights, and experiences that are brought through art, especially music. And so I know there are other genres where this is also incorporated, but I think it's really, and I would love to hear if you guys want to put those in the chat, if you can think of other genres of music or other examples where you hear individuals talking about their individual experience or an experience of a collective or community. And so I wanted to share lyrics from a hip hop artist by the name of Sadat X. And he's also part of Brand Nubians, which is a pretty famous 90s hip hop group. And I lift this up because I want us to understand that the social determinants, actually come in various forms. We hear them in music, research, and other forms of expression. And so this is Sadat's lyric. Cancer is the great imitator. Sometimes it reveals itself much later, from a boss to a waiter. It don't discriminate. Hodgkin's disease, leukemia, cancer of the colon and the prostate. You need to get yourself straight. Cancer of the lungs is rising. The first thing you do in the morning is buy a Lucy. It feels like a boost. It's a threat in that skinny cigarette. Exposed to asbestos in the air, in that jail, they weren't playing fair. Stuff was everywhere. That's why I lost 2 brothers that year. Lymphoma, melanoma, this little place in Oklahoma, devoted to the study that killed Rena and Mr. Chin, my neighborhood cleaner. So there are examples that we hear in music. We may sometimes dismiss them because of stigmas that are tied to the music, but this is an individual that's telling a story not only about his family, but also his community. So I just wanted to briefly talk about some of the modifiable factors that we talked about earlier. And so smoking, we know that smoking and using tobacco products is the leading preventable cause of cancer and cancer-related deaths. And while we made a lot of strides recognizing that threat that smoking poses to public health, and we've enacted policy prevention efforts like indoor smoking bans, Black and Hispanic neighborhoods are still the target of predatory advertising, right? So Black and Hispanic neighborhoods have more advertisements, as well as advertisements for cheaper tobacco products like cigarillos and menthol cigarettes. So we know also some of this has to do with the built environment in the neighborhoods in which a lot of individuals live in. Next, I wanted to talk about obesity, diet, and exercise. And being overweight or obese, diet and physical activity are all interconnected and important lifestyle factors related to cancer risk. And we find in predominantly Black neighborhoods, they're less likely to be able to afford or access healthy food options. And generations of racist policies like redlining have forced people of color into food deserts and low health resource areas. So even if there are healthier food options that are available, they can be cost prohibitive, especially for families who receive federal nutrition aid benefits like SNAP or Women, Infant, and Children, WIC. So the safety and walkability of these neighborhoods can also influence your ability to lead a healthy and active lifestyle. 43% of predominantly Black neighborhoods and 46% of low-income neighborhoods were in the lowest tertile of healthy food available within this Franco study, and that's the figure that's actually shown here. And this is availability versus 4% and 13% respectively in predominantly white and higher income neighborhoods. And so I also use this because one, it's insightful research, but then also this was ahead of the wave in 2010 that I talked about related to social determinants of health. So I tell everybody, check out Google Scholar because they have like a bar graph that will show you like the number of publications that happened between 2000 and 2010 in the 2010s. So with this wave came more graphics, theories surrounding social determinants, and the influence that it has on the public's health. Next, we'll talk about pollution. And as Erica mentioned, I went to undergrad in Louisiana. So this is a research study that's near and dear to my heart. But pollution is another issue that we often don't talk about, but they're also tied to the social determinants. And so residents of urban areas and persons living near industrial point sources have greater lung cancer risk compared to persons living in rural areas. This study is a great study because it shows Cancer Alley, which is in Louisiana, and they have a high proportion of Black residents that also have low social economic indicators and a concentration of toxic emitting factories. So these huge toxic releases that happen, as well as water discharge permits that have been granted to these facilities in the area. But we see that as the percentage of Black residents increase, so does the cancer risk. And the cancer risk actually increases 12 to 16%. In the low income or Black dominant tracts compared to the high income tracts within this area. So in 2012, that's what we were able to see. So we're starting to get more and more data to show these impacts and risk. Next, I want to talk about mass incarceration. So racist policing and judicial systems, sentencing and cash bail policies have directly resulted in the mass incarceration of Black people in America, having far-reaching negative effects on a formerly incarcerated person's health as well as their well-being. And despite consistently being shown to reduce recidivism, people with a criminal record may actually lose eligibility for social programs like SNAP and TANF, and they also face housing and employment discrimination. So that has an impact on their economic ability, right? And so this discrimination affects not only the individual, but their family and community as well. Next, I want to talk about the distrust in the medical system. So there's been historical medical mistreatment, and unfortunately, we can still say that there is current medical mistreatment of Black people in America and other people of color, and that's contributed to a mistrust of healthcare providers within these groups. Patients of color are less likely than white patients to report being the same race as their healthcare provider. Last week, I watched a pretty amazing webinar called Health Leads, and the guest was Venus Genies, and she's actually she lives in the state of Georgia, and she basically provided this quote, and I thought it was really interesting. Misinformation plus miscommunication plus misconception equals mistrust. So over time, if there is misinformation, all of that can really have an impact and build this distrust that's within the medical system. And I want us to consider these numbers. Black adults were less likely to report being the same race as their healthcare provider, so about 22%, than white adults, which have about 73%, 74% of the same providers, or adults of other races, which was about 35%. And then less than 1 in 4 Hispanic or Latin adults reported sharing a racial, ethnic, or language background with their usual healthcare provider. And so these disparities can have negative implications for patient-provider relationships and patient health outcomes. Early detection, we know, is really important. And early detection and intervention, right, are both really important and critical to ensuring better cancer outcomes. And so for patients who are less likely to seek routine preventative care for screenings will suffer worse outcomes. Many preventable cancers are also caused by viruses. So mistrust may influence someone's decision to actually get themselves or their child vaccinated against these viruses. And so I have another lyric, and it describes a patient's experience. His name was Too Poetic, and it was on a song called One Life. Paralyzed on the bathroom floor by pain. Last month I endured, but now I can't ignore. Feels like railroad spikes being stuck in my liver. Am I dying? Eyes crying, body starting to shiver. Crawl upstairs from the basement, calling my sister. Dawn, help me. I ain't feeling too healthy. 3 or 4 docs in the room. Test results suggest your colon and your liver is so cancerous. You got 3 months left. And so Too Poetic was a rapper. He was a hip hop artist that was part of a group called the Gravediggers. And he passed away, unfortunately, on July 15, 2001. And this was almost 3 years after his initial diagnosis of colon cancer. And here we have a qualitative example of an individual and their experience with cancer, as well as provider interactions. And I'm not trying to imply that Too Poetic had distrust in the medical system, but depending on his previous experiences, that could have had an impact on when and where he actually sought out care. Next, I wanted to talk about weathering. So all these factors, tobacco use, diet, obesity, pollution, mass incarceration, viruses, historical mistrust, they all compound and accumulate over a lifetime. So this process of cumulative wear and tear on the body due to adaptation to stressors has a name. We call it weathering. And so this was proposed by Geronimus in 2006, and it's characterized by an ever-increasing allostatic load. And that's when the wear and tear on the body accumulates as an individual is exposed to repeated or chronic stress. And so the harmful effects of this stress on health is well documented. High allostatic load has been linked to greater cancer mortality risk and to decreased cancer treatments. So in a vicious cycle, greater stress may really lead to unhealthy coping mechanisms like smoking, alcohol consumption, or binge eating. And the social determinants influencing who's most at risk of developing and surviving cancer are really clear. And so the foundation really believes that health equity is racial equity. And much like the Indiana Cancer Consortium, we continue to focus on and work towards cross-sector solutions that provide communities with the tools that they need to build a healthy infrastructure that's centered in equity. So I just wanted to take a little bit of time to talk about our journey within the foundation. And so when we talk about social and structural determinants of health, health disparities, health inequities, the whole hodgepodge and alphabet soup of vocabulary, we really want to show you how the foundation became so focused on social determinants of health and equity. Most of this is before I got to the foundation. So I wanted to still share the story because I think it's really important for you all to see how we've actually transitioned. So in 2008, the foundation formed the Commission to Build a Healthier America to investigate why Americans aren't as healthy as they could be and look outside the healthcare system for ways to improve health for all. And so the commission studied prevention, they studied wellness and broader factors that influence good health, conducting site visits, they heard testimonies from experts, and then they issued these 10 recommendations. And so many of these probably hit home for all of us, right? Feed children only healthy foods in school. Create healthy community demonstrations to evaluate the effects of a full complement of health promoting policies and programs. We're all probably shaking our head in agreement that these all make sense, but back then in 2008, this was really pretty much cutting edge stuff because remember, like we said, the social determinants really didn't start that wave of increased discussion and publications till about 2010. And then next, the commission also helped to inform this new guide, a new way to talk about social determinants of health, to expand views about health in America, to also include how our health is influenced by where we live, learn, work, and play. So like I said, remember the Google Scholar search, this was around the same time, and it probably wasn't a coincidence. Next, I wanted to talk about our county health rankings. And so this provided an unprecedented county by county look at key data on a range of health factors outside the doctor's office, including high school graduation rates and unemployment. And this is a partnership that we still have with the University of Wisconsin Population Health Institute. And so these are annual county health rankings that measure vital health factors, including the graduation rates, obesity, smoking, unemployment, access to healthy foods, the quality of air. And these rankings really provide a revealing snapshot of how health is influenced by where we live, work, play, and also a starting point for changes that want to happen within the communities. And so I just wanted to show the 2021 health outcomes for the state of Indiana. And those are based off of the length of life. So they have data that's tied to premature deaths from 2017 to 2019, and then the quality of life. So in the survey, was there a fair health outcome, poor physical health days, poor mental health days, or low birth weight? So I just wanted to bring to your attention 2 counties. So Warren County, which is on the right side of the screen, they rank about 18th. Within all of the counties of Indiana. And then Jay County on the opposite end, on the right side of the screen, that's initial JY, is 83rd. So you can see the disparities even within the state of Indiana, and how that all plays out. So this is information that's available. Again, county health rankings is still done on an annual basis. Next, I want to talk about our life expectancy map. So in 2013, we launched the Culture of Health Prize, which I already talked about. And then we had a collaboration with Virginia Commonwealth University where we released these life expectancy maps. And so like the rankings, they really help policymakers, civic leaders, and other influencers across the country illustrate how health is connected to every aspect of our lives. So unfortunately, we didn't have a Indiana diagram, but I did find Chicago, which is the closest to you all. And this just exhibits the differences, which is only a couple miles between, I'll highlight 85 years in the Loop, which is further north of downtown. And then in Washington Park, there's a 14-year age difference on the south side of Chicago. So this gives you an idea of the life expectancy of individuals depending on where they live. In 2014, the commission also built and issued a second round of recommendations, really stressing the importance of increasing access to early childhood development programs, revitalizing low-income neighborhoods, and broadening the mission of healthcare providers beyond medical treatment. And then in 2014, the foundation released an action framework, and that was basically, it included 41 evidence-based measures that pointed to greater well-being and health equity for all. Some of you may be familiar with this diagram. So we continue with our drumbeat for equity, creating an online health equity toolkit and unpacking the concept and feature stories and actions for various sectors. And so this included the bicycle graphic, making the case for equity, not just equality. And so with the release of What is Health Equity, which was led by Dr. Paula Braveman, it offered a formal definition to guide our work and formally assert that health equity surrounds and underpins our vision. And it also highlighted the lasting effects of institutional or structural discrimination, such as residential segregation. And I can give you all the definition for health equity. It means that everyone has a fair and just opportunity to be as healthy as possible. This requires removing obstacles to health, such as poverty, discrimination, and other consequences, including powerlessness and lack of access to good jobs with fair pay, quality education and housing, safe environments, and healthcare. Next is just an example of our life expectancy calculator, and we did this for Marion County in the state of Indiana. And as you can see, the United States has a little higher life expectancy than the state of Indiana and then of Marion County. And so in 2018, we externally actually looked at our focus and did which really prominently spotlighted racial equity. And this was a Discrimination in America polling event that took place with Harvard and NPR. And it showed through data that discrimination is a prominent and harmful way of American life. And meanwhile, like I said, the life expectancy calendar also came out in 2018, just to show how opportunity can even vary from block to block. And in 2020, I actually started with the foundation in 2019. So in 2020, when the I was with the foundation for about 6 months when the COVID pandemic hit. And so around that time, our senior leaders, specifically Dr. Richard Besser and Dr. Julie Morita and other RWJF messengers actually became leading voices that called out the inequities that keep some suffering disproportionately, including people of color, workers with low incomes, and people living in places that were already struggling financially before the pandemic. So this really leads up to today. The pandemic has made it clear that the biggest barriers to health equity in America have been created by systems and structures that privilege some and disadvantage others. And structural racism is at the top of that list. It intensifies every other form of discrimination and intersects with all of the social conditions that also impact health. And so that's why the foundation has really doubled down on advancing health equity. And this includes a strong focus on addressing these structural barriers to health, including racism, other forms of discrimination, and social conditions that impact health. So this really isn't a sharp turn off of our path. We're just sharpening our focus. And we're really glad to be on this type of journey with groups like the ICC. So next, I wanted to talk about our work with the American Cancer Society. So we partner with ACS for years, and most recently in two areas. And I really want to give a shout out and a huge thanks to my colleague, Shuma Ponce, who works with the American Cancer Society on this work. She's leading that work. And she also introduced Mary and I for this speaking opportunity. So just wanted to briefly talk about our relationship with ACS and also focus on number 3. So there was a call out recently by ACS to fight racism and other forms of oppression. And that information is also on their website. But it's we basically help to fund ACS to embed health equity across those different facets within their organizational work. We also partner with ACS, the ACS Cancer Action Network, most recently on a Medicaid expansion campaign to really apply pressure to the 12 states that have not yet expanded Medicaid. Next, I wanted to talk about some of the information that stems and sits in what we call research, evaluation, and learning. That's where I sit. And so we're funding a lot of research about racism in the healthcare system, and even our evaluation practices and the number of evaluators and types of evaluators that we use are changing, because we're now approaching evaluation and evaluative work understanding that it should be in service of equity, and it shouldn't sit, these evaluations can't sit on a shelf and collect dust. We actually need to be able to have learnings and findings from those where communities could actually utilize the information. So within the foundation, looking at the ways that racism, public health, and healthcare intersect is really at the center of the research that we fund. And one example of that is the Evidence for Action program. So this program actually funds research that evaluates specific interventions that have the potential to counteract the harms of structural and systemic racism. And they also want to improve health, well-being, and equity outcomes. So through this program, we really focus on studies about upstream causes of health inequity, such as the systems, the structures, the laws, the policies, the norms, also the practices that determine the distribution of resources and opportunities, which in turn influence the individual's options and behaviors. Next, I wanted to talk about the foundation. I think we established, as far as we know, we established the first of its kind independent national commission to transform public health data systems. And Joe Gibson, actually, I'm working with Joe Gibson, who I think was, who's in Marion County. We're actually working together on one of these projects. And the commission is actually including some of the nation's leading experts in areas such as healthcare, community advocacy, government, business, and public health. And they were really tasked to identify the improvements in data systems that will better address social determinants and structural factors that really result in these inequitable health outcomes. And all of this information is also on our website if you're interested in finding out more about the commission. So I think you'll agree with me when I say research is an essential tool that can help to ensure that health and social policies enacted during the pandemic positively affect communities for decades to come, but also calling for more research and framing racism as an upstream public health issue can't alone dismantle racist institutions or support community healing. So we really have to take a focus and evolve from what they call public health 3.0, which emphasizes cross-sector collaboration and improving social determinants, to public health 4.0. And that's really community-centered, is driven by those that are most affected within the community. And then it also addresses structural racism as a public health issue in and outside of the context of the pandemic response. And so ACS calling out racism as well as over 200 declarations of racism as a public health threat by cities, counties, and states. That's a start, right? Like the public health 4.0, I think we're well on our way, but we have to ensure that that is actually implemented by a number of communities throughout the country. So we know that public health has traditionally been severely underfunded. And since 2010, the spending for state public health departments has decreased by about 16% per capita. So even in the midst of the pandemic, several states have continuously decreased their public health funding. And so we know that we need to invest and reinvent in our public health infrastructure in order to put public health on solid ground. We must center our public health system on combating racism and create modernized data systems that account for all people, not just a specific set of people. We also must make sure that public health officials have a seat at the table when discussing all aspects of health, be it housing, education, food access, or even minimum wage. Equity needs to be the lens that we actually peer through moving forward with our public health systems. And so something that I've really been focused on recently is the racism that exists in research. And so last October, I was able to co-author an article titled Addressing Racism in Research Can Transform Public Health with a number of my colleagues at the foundation. And that was published in the American Journal of Public Health. And so in that article, we state that in order to achieve health equity, we really must name and identify racism where it exists. Challenge the structural racism that shapes our governance, social structures, and policies that perpetuate these inequities. And research must really provide an evidence base for future policies and interventions that must be implemented at the individual and community levels in order to enhance that health equity for all. We provided 4 key recommendations for what this could look like. And this is also kind of a call out of the foundation sector as a whole as well. And so some of this, that what it could look like is a deeper examination and commitment from journals, funders, and peer reviewers to explicitly name institutional racism in public health literature. There is some literature that shows that most of the time institutional racism is not called out within the literature. Also, an investment from funders in the philanthropic community to ensure research is conducted by a diverse body of researchers in partnership, not extractive, in partnership with the community. Also centering people who bear the greatest disparities, primarily Black, Indigenous, Asian American, Pacific Islander, Latino, Hispanic, and other communities of color need to be included in this research design, implementation, and also policy advocacy. Also, finally, practice-based research really needs to shift the paradigm to investigate the joint effects of multiple domains of racism, structural racism, interpersonal, and as well as cultural. So we really can better measure racism and not just its effects. So we need to invest and enact evidence-based policies that really address these historical inequities. So with all of that, I know you guys are probably like, well, what can we do? Like, Jackie, take us home. What is this all connected to? And I think when we look at cancer through the lens of health equity, it becomes clear that cross-sector collaboration is crucial in combating racism and addressing how the social determinants of health impact cancer outcomes. And it's not to say that you all aren't doing the work. I believe that you all are doing the work. I love the, I think there was a focus on data and advocacy in some of the areas, which is like pretty amazing. That is happening. I don't want to take that away from you all. I think we also, these are just things that we can all consider and continue to think about and how we do these things and who's at the table, even taking a role in understanding of who's at the table and do we need to modify some of these these collaborations. Another thing is we have to strive to have a diverse workforce in healthcare and also in research. It's not just the bedside. There are other places where we have to ensure that we have diversity within the workforce. And in the makeup of our healthcare providers, that has the potential to increase health equity and reduce disparities. And then having a diverse group of researchers can also bring different backgrounds and experiences that are crucial in collecting a more representative data set. Next, we need to continue to modernize our public health data infrastructure and really utilize data disaggregation in an effort to make sure people are not slipping through the cracks and slipping through our data gaps. We really must invest in these data systems that allow us to see the full picture of our communities, of how different social determinants of health are really disproportionately impacting our different communities. And so when I talk about established ideas with an innovative twist, that's really tied to Public Health 4.0, right? We must continue to implement those types of ideas into our work. And through the lens of cancer, it means looking at which populations are affected disproportionately by these cancers and making sure that the response from the cancer community is driven by the community's voice and address their needs. It's imperative that we use their social determinants of health as drivers towards what needs to change to prevent cancer in different groups. So also I wanted to bring up the 21st century communities. And I think this is something that is a project that the foundation also supports through the Public Health National Center for Innovation, which is part of the Public Health Accreditation Board. And so they expanded to include states that are transforming their governmental public health systems. They're modernizing and advancing equity through a variety of strategies and models, but they're not limited just to the foundational public health service model. And I think that's tied to accreditation in some of these boards, but I think there is an opportunity there. I don't think Indiana is incorporated into that right now, but that's an opportunity to utilize your established ideas and add this innovative twist within the public health departments. Next, community engagement. I think every community should continue to be at the table. They have the working knowledge. We have to engage and listen to the community, especially our employees, our patients, our residents, like all of those people really bring so much into our spaces. It's really important to hear them. And it may not be delivered in a way that we consider normal, right? But just like the rap lyrics I used earlier, there's still a theme and a very important message that's coming from the individual and collective that can be a great takeaway. Also, I say be accountable and be accountable to yourself and each other, because accountability starts with language, and we can't silo any of these problems and try to redefine the issues in language and expect different results. Next, I say ask for help. This applies to everyone. I think translation, interpretation, always remembering that we need the evidence, and the evidence, like we actually need the evidence, but the evidence needs us. And so theory is great, but theory and practice are a 1-2 punch. So maybe you don't have the rigorous research training, right? But someone that you're in the collaborative with right now, or someone in the consortium may have that, right? So how do you work together to ensure the information is well received by the intended community? And that my next point talks a little bit about that. And so trying to address racism and the way it's manifested in cancer causes, treatments, and outcomes is really important. There's no one-size-fits-all solution to combating racism. And it will really take a commitment, difficult conversations, sincere reflection, and humility from all of us to move this ahead. So it's really crucial to examine the mechanisms through which we continue to perpetuate racism and the methods critical to addressing it to lead us to a future of health equity. We have to stop circling around these issues and say what they are and how they impact our communities. Like I said before, language really matters. And these are things that you should think about: is what do the words we use communicate about the people we serve? How do the terms and phrases align with organizational values? Is the language precise? Is it unbiased? And so that was something that I read in an article by Geetha Morali and Christy Hengrains last week. That was called "Using Dignified Language Unseats Bias and Advances Equity." And so what we have to continue to do that and lift up the communities that we are serving. And what we really can't do is skirt around justice and equity and leverage the language of diversity and inclusion to their own benefit while we're really perpetuating something else in reality. So by naming social determinants, by naming racism in peer-reviewed literature and other places, and being explicit about how systems and institutions are designed to isolate and oppress people of color, we can really analyze these factors and influence population health patterns. Finally, cancer touches everyone, right? And these are community-wide issues that cannot be tackled by one individual. United fronts will really be essential, especially when trying to tell a story to influence, create, and change policy. There's so many examples of the its or social determinants around us, so let's listen, ask questions, bring the community in, but not in an extractive way, and translate without redefining what we hear, because we really don't want this history to repeat itself. And I'll end with a verse from Harold Melvin in the Blue Notes. And this was modified for the consortium. Wake up all the consortium, make the people of Indiana well. They're the ones who suffer and catch all the hell, but they don't have so very long before the judgment day. So won't you make them happy before they pass away? The world won't get no better if we just let it be. The world won't get no better. We gotta change it, yeah, just you and me. Thank you.
Thank you so much, Dr. Orr. And I know I've seen it in a few of the comments, but yeah, many people commenting on loving your music references and really incorporating that. And again, that real life perspective. So we really, really appreciate that. It was such a wonderful presentation. We do have just one quick question in the comments that I do want to address. They commented on the culture of health and how it promotes to keep health and well-being at the core of every aspects of our lives. However, we're still facing cancer disparities due to residential segregation and hypersegregation. How do you think we should address this problem, in particular to promoting participation in clinical trials, cancer screenings, treatment, and survivorship?
So I see that there are multiple questions in one, right? So I think part of it is like the hyper segregation is one thing, right? Like that, I mean, understanding what that looks like. And I think this really all comes down to being able to tell stories, right? Like having that information, having the data, having the community members like provide input about there are qualitative and historical perspectives that may come from the woman that's lived there for 80 years. Like there's information that could be very helpful in understanding why the segregation actually exists, and then using that to inform policy, right? So it's almost a tension, but it's like the opportunity to be able to tell the story to the policymakers, to be able to address some of those things is one part of the question, I think. But then the other part, like as far as clinical trials, I think that still has quite a ways to go, because I think there's that mistrust, there's this distrust in the system, and part of that has to do with the patient-provider relationship. And so even as Amy mentioned earlier, like asking the questions, not necessarily making assumptions about individuals, that can start it. But I think there's also from like the IRB and pharmaceutical perspective, there may be other things that can try to help address why there are barriers, but I can't really speak to like the recruitment. I think that may be part of it, but it's also how you build those relationships within those communities. You can't just come into a community and expect that individuals will trust you, right? That may take time. And that's even something that the foundation is learning. It takes time. We can't, in some of these instances, it may take us 2 years to build that trust and have a community allow us to then start discussions. So I think it's mainly, I would say, start with building the relationships, and then there could be a potential possibility of having 1 or 2 leaders from the communities talk to you about why. They can probably provide additional insight as to why there is why there are barriers to be able to get more participants.
No, absolutely. And it's definitely layered, but I appreciate your thoughts on taking one step to move forward in that. So we do have to move to our break. I know we have another question that is in the chat. So Dr. Orr, if you have a chance and availability to answer in the chat, greatly appreciate it. Otherwise, we can follow up with you after. But again, thank you so much. It was absolutely a wonderful presentation, and I know I got a lot from it, and I'm sure everyone else did. So thank you so much for your time today.
Thanks so much, Mary.
Thank you. So we're going to go ahead and head to our break. I'm so sorry we shortened it a little bit, but I think we've had so much packed information today. So feel free if you need to take a break a little bit later, we completely understand. So, but please join us back in just about 6 minutes at 10:45 for our next presentation. Thank you. All right, it is 10:45. I know, I'm sorry, that was a quick break, but we do have a lot of exciting couple presentations left. So I'm going to go ahead and get my slides up and do a recap and talk about this last year for the ICC in our community. All right, so we didn't get a chance to do this last year at the annual meeting, but we have done it in the past. And so I just want to take it again, like I said, a chance to recap what happened in another crazy year of 2021 and really talk about where our community and the ICC is going as well. Again, always wanting to highlight, as all of you know, our mission, really working to reduce Indiana's cancer burden and working with our entire community to do so. So we could not do without any of you. And again, events like today making us move forward. So again, this past year, facing another time of the pandemic. It was definitely a year of progress, a time where we all had to be really innovative just to do our day-to-day work, to keep things moving forward, and even more importantly, keeping an eye on cancer, which we know does not stop for any reason. And it also was a time of some great achievement. We had some great community programs that had some great results, making an impact in our community, even during a really, really trying time. So again, thanking all of our members and all those in the cancer community for keeping moving forward when it was really hard. And so we just want to take some time to reflect and look at some highlights. Specifically, taking a quick look at the ICC by the numbers, as we've seen, having over 400 combined individual and organizational members, really having that collective power action. We had over 20 unique committee meetings throughout the year. In an effort to bolster our social media and having to create a new Facebook account for organization, we still achieved over 30,000 social media impressions and reach. We were featured at 6 webinars and 1 conference at the Indiana Wellness Summit. And through our greatly donated time by our members and other folks, we had close to 150,000 in-kind support received. And on top of that, we were happy to be able to provide 35,000 in grant dollars to our community for different projects related to the cancer and implementing the Indiana Cancer Control Plan. It's a great transition. Again, reminder, we've said it many times today. I won't spend too much time on it, and I might fly through some of these other slides. But remembering that the Cancer Control Plan really is a roadmap for what we have going on in our state, how we can work together. And again, we're going to be creating our new plan very, very soon. And so I'll be talking about that later in our message in the presentation. But you should have all received this as well in the materials this morning in the email. Again, just reminding that the framework, again, all being evidence-based strategies, supporting our goals around primary prevention, early detection, treatment, and survivorship. And you can see those puzzle pieces, which is kind of a really nice visual theme that we like to use about how everything is really interlocking, working together. I think Dr. Orr's presentation was, again, great evidence of that. So those are categories that our evidence-based strategies are split into, and that we hope you all really utilize as you are creating your work, looking at your strategic plans and working, looking at where to go in Indiana. Again, a highlight, just like this meeting, our annual meeting last year had over 150 attendees, was another virtual setting. Again, I think we're going to be in person for our next one, so very excited about that. But again, just highlighting one of our great events from last year. Our cancer prevention and screening and survivorship care ECHO has been a great success. So in 2021, we really looked and spent a lot of time planning for our 3rd launch that happened in January of this year, as well as continuing on our 2nd year. So in 2021, we had 19 didactic and case presentations. We had over 451 attendees. And again, this is an example about carrying out the cancer control plan and really utilizing the strategies in it. And on top of that, I had the pleasure of co-authoring with Dr. Tyler Severance and a lot of our other hub team members research on the successes of year 1 and 2. And so that was able to get published in Cancer Medicine last year. So we're just very excited to see our work in Indiana being out there for the community as a best practice. Now I want to take some time to really touch on our committees that have still been thriving and going throughout COVID, and really, again, thanking all of our members for participating and giving their expertise. So again, want to touch on a little bit about what they do, kind of oversee, and what specifically they've accomplished in the last year. So our early detection committee, as you can see, really works to increase screenings by reviewing and understanding our state's challenges, and then designing initiatives to help educate and increase screening rates. And so our committee has really evolved throughout the years, taken on different projects, but again, one of the main things is overseeing our employer gold standard program and providing technical assistance to that, which I'll touch on a little bit later. But like one of their current activities is our early detection webinar series, which is ongoing right now. And I think we're going to be posting some information in the chat soon. But again, providing more opportunities to network, to share best practices, especially during 2021, where there was an influx of changes with COVID mandates, the rules in different areas of the state. Committee members were really able to provide each other with what was working for them, what wasn't, and really overcoming some of those challenges. So. And then to our evaluation committee, really important role. It really gives opportunity for our members to provide feedback, information as it relates to projects the ICC is doing, how we're functioning as a whole. So I really encourage folks to join all of these committees, but especially this committee if you'd like to have kind of more input based on a lot of the evaluation surveys that you see here that we do. A great opportunity to get involved and make some change so we can better serve all of you and all of the organizations in the state. I will say that these are some of the names of the surveys we put out, and in May, we're going to be releasing our member satisfaction and effectiveness survey. And again, that's super important as we figure out how we can, again, best serve our members and reflect the work that we're doing. So I encourage you all to join. And just example of how we use some of that information. So we want to make sure that you guys know that once we beg you to take these surveys, we throw them out there, that we are doing a lot with the information. We're not just having a survey to have a survey. The evaluation committee oversees action plans. We take that information, we try to make it actionable, useful, and again, improve what we're doing. And so these are just some examples. There's more in the booklet today about how we're using these surveys, how we've created action plans and are trying to make things better. Then on to our ICC data committee. This data committee is super interesting. I encourage folks to join. Again, we are really looking at the quality, quantity, timeliness of cancer data, especially as it relates to not just cancer data, but health data in general that influences cancer, looking at obesity, nutrition, activities, so on, as kind of is the theme of the day, that are all contributing factors. But this committee, again, like others, oversees a number of projects as capacity and interest allows. So the Indiana Cancer Facts and Figures is overseen by this committee and other experts that we reach out to. Again, working to identify the challenges, the gaps in data that we're seeing. Survivorship has been a lot of conversation of the past year, as well as reviewing and analyzing new data reports that would come out and see how they're relevant to Indiana and the work that we're doing. In that sense, I just want to remind folks about our cancer control plan dashboard that's on our website. So this is just a screenshot, but it is interactive. We update it as soon as we get information from Burfus and the registry and other resources from our great partners at the Department of Health. And again, interactive. So if you want to see what's going on based on the measures and data that's coming out, we really encourage folks to utilize this. And again, the Indiana Cancer Facts and Figures are on our website. So to touch on the employer gold standard just a little bit, it's a recognition program designed by the Early Detection Committee. It is a free employer wellness program who really recognizes employers that establish the workplace as a primary place to focus on primary prevention and early detection for breast, cervical, colorectal, and lung cancer. And so we work with employers of any size, of any industry, to help them create and expand on their employer wellness program to create a cancer action plan. So within the last year, we were able to provide some mini grants to the organizations you see below. And so we are really happy to recognize them and congratulate them for really taking this on and showing an initiative to really care about their employees, care about their health, especially as it relates to cancer. So through these organizations that we onboarded in 2021, over 36,000 employees were directly impacted working for the employer. But then we also do a lot of efforts to work with the insurance of the employer. So taking into account the lives that are impacted and covered under those insurance plans pertaining to those employees was actually over 61,000. So really excited to be partnering with these wonderful organizations. And again, we have more information on our website. I think I'll be sending out a lot of links at the end of today. And I apologize because I know I am really running through this recap of the ICC, but I just want to make sure we're staying on time. Again, how to join. So on our website, we have an application of intent, which really just outlines information about your organization, how many employees you have, what kind of insurance. And then our goal is really to address at least 2 of those cancers, breast, cervical, and colorectal. But it's really interactive, collaborative process between our technical assistance committee and your organization, whether that be your HR person, your health leader, whoever is designated as our contact, and really work with you. We provide examples, toolkits, resources, again, our expert committee to provide that evidence-based intervention ideas so we can work on an action plan with you. And again, that technical assistance is provided. And then we use opportunities like the annual meeting, our website, newsletters, things to really recognize all our employers that are making this a priority. I also want to touch on our Tobacco Prevention Cessation Health Systems Change Grant, which we have Gage Van Dyne as our Tobacco Prevention Cessation Coordinator, who's working very hard and diligently with cancer centers in our state to work to have a robust health systems change around tobacco dependence and use. And so really want to recognize the great work that's been done within the last year, working with Ascension St. Vincent Evansville and Good Samaritan Hospital, starting within their cancer centers and really expanding beyond that. And so you can see some of the highlights here, including, more than 80 staff trained in general and getting updated on TPC best practices, our intervention processes, policies, and so on. So a lot of great work and a number of counties and even states impacted through this. I also wanted to take a moment to touch on advocacy. As being a shorter session this year, there was a couple movements going on. And so the ICC really took initiative to support our organizations and partners like ACS Can to really push the evidence-based messaging and sharing what the science is showing us, what the data was showing us, especially around the tobacco tax and coverage for colorectal cancer screening. So just want to highlight letters to the editor, messaging, and that our eyes are on advocacy, and we look to expand this as we move forward for the ICC. And just a quick touch on a participation that the ICC, our program ICC participated in with the Department of Health, led by them, as they were invited as our comprehensive cancer control program to participate in our Tri-Networks HPV collaborative. And again, you can see the goal there, but it was really to increase our vaccination rates. So we, with the Department of Health, did some targeted outreach to our counties who had low up-to-date rates, and really targeted physicians, hospitals in that area, make sure they were still getting the messaging out around HPV vaccination, even during a time when we know the conversation was largely around COVID. And that was paired with a back to school HPV public service announcement and campaign. And that was all through a combination of digital ads, radio ads, interviews, and a whole sorts of mix. So we partnered and participated with 7 other states in this. And again, it was a nice touching point for a back to school time. I'm going to take a moment to just touch on where we're going, and the next 2 slides are a little bit similar, but continuing to partner to bolster that. We wanted to continue to form, again, educate our community through events like this and others, getting the evidence-based interventions, information, and science out there, and make sure it's up to date as possible, connecting all of you and make sure there's opportunity to network, collaborate. Again, I've touched on advocacy, and then also recruit, bolster our membership, making sure we're having that representation from every everyone that really needs to be at the table and being intentful about that. So I think that's really reflected in our priority pillars that you see us as we plaster this everywhere and all our publications and everything. Our priorities are unchanging in that sense. So very excited to keep moving forward. And again, how to join, how to get more involved. This is just a highlight. There's a lot more in the booklet, and I'll be sending some more messaging out after the annual meeting today, but there's a plethora of ways to get involved from any level that you can participate. So, you know, it's some people participating at just reading our newsletters and sharing that information. We are very excited and happy about that. We understand everyone goes through waves of capacity. And if you're able to join a task force or a committee or want to talk to us about starting one, we're more than happy to have that conversation. Again, upcoming cancer control plan that is going to be out soon. As you see, the current plan is expiring at the end of this year. So the ICC and our partners are taking a look at the process right now for the next cancer control plan. We will be forming a steering committee in the next month or so. And this committee is really going to help oversee the process of the cancer control plan, as well as look at the last two processes that these plans were formed, see what we like, what went well, how can we improve, and really provide that opportunity to provide feedback, as well as to engage other stakeholders that aren't at the table. So we are welcoming folks from all different walks of the cancer community, and we encourage you to reach out. Again, you can reach out to the admin at indianacancer.org email as well if you would like to join. And our last note, something that I'm really, really excited to highlight, again, not a reflection of last year, but on the note of where are we going. So I'm excited to share with all of you, and I've shared with our committees, but in a larger sense, that the ICC is partnering with the American Cancer Society and additional funders for a public health campaign focusing on African Americans. And so this campaign is really designed to increase the awareness and need to screen for various cancers, really familiarize African Americans with screening guidelines and timeframes, as well as motivate those who have not been screened to really get their screening tests on the books. And so it's a really multifaceted campaign that originally launched in February and will go out through the end of this year at least, and actually maybe push into January of next year. But we've created a marketing campaign utilizing both traditional and social media routes, so radio spots, ads, all the social media, as well as utilizing videos and other local stories to really share that impact. And so we have produced a video series highlighting African American voices from our community who have been impacted by cancer. So I'm very excited to show one of those next. But I wanted to highlight that this campaign will have different tones throughout the year. So not only being Cancer Control Month, but by Minority Health Month as well. A lot of our messaging and the tones of these ads really reflect that, and we'll continue to do so through our Cancer Awareness Month throughout the year. So we really hope that all of you can help circulate this message around. While all of these campaigns, videos, everything really gets back to the ICC's website for a landing get screen page, which you can see a screenshot of here. And so I know I'm running a little bit over. I apologize, but what I'm going to do is go ahead and play the video next, and this really wraps up my presentation. So let's go ahead and see if this will. Let's see. Now, can we see the screen, and do I need to reshare?
Mary, you are good.
Okay, perfect. Thank you. Sorry about that. Now I lost my, here we go.
Cancer screening is important and its benefits are massive. Early detection is key. When I started my medical journey, one of the things that one of my doctors said to me was, this is a curable condition.
Stop.
I am Alicia West. I'm a grandmother and I am a cancer survivor.
I was diagnosed with lung cancer.
Oh no, thanks for everyone letting me know it's not the actual moving. Sorry about that, everyone. Let me go ahead and share it straight from YouTube, and maybe that will help. My apologies.
Cancer screening is important and its benefits are massive. Early detection is key. When I started my medical journey, one of the things that one of my doctors said to me was, this is a curable condition. I am Alicia West. I am a grandmother, and I am a cancer survivor.
I was diagnosed with lung cancer in 2000.
My mentor fought 4 years, a long journey with colorectal cancer, and he passed on my birthday.
When talking to patients about how important it is to get screening, I try to stress the importance of, do you plan on being here? Do you plan on having a family? Do you plan on enjoying life?
If Jason was here today, what Jason would tell us is, get screened. Get screened early. Cancer waits for no one. Please get screened.
If you think life is worth living, then to take some personal responsibility for your health. You've got family and friends. I'm sure you'd like to see some of them grow up.
1 in 2 people is 1 in 2 people in your household. So it's myself or my husband. It is my parents or my grandparents. So it hits home because cancer is not selective. If we don't take care of things before they happen, then all we're doing is ever treating disease instead of preventing it from happening. I hear often people say, I'd rather not know. But you're gonna know. One way or the other, you're either gonna know.
Mary, you have to come back off of mute. It muted you. It muted.
Sorry about
For
that.
everyone by the age of 45 to be getting colorectal screening and breast cancer screening with mammograms.
Cancer screening can save your life. Take some responsibility for your own future.
Cancer won't wait. Get screened.
All right, sorry about that, everyone, with the the few hiccups with the audio. But again, that is posted on YouTube. We are going to be sharing it with everyone after the meeting, and we hope that you share it with our partners and are able to share on our social media. So I just thank you for allowing me the time to share a little bit more about the ICC and the work we've done and the work we've all done as partners. And I'm very happy to hand it off to Dr. Rawl next to introduce our last session.
Great. What a beautiful video. Thank you to everyone who was part of putting that together. Very well done. My name is Susan Rawl, and I'm with the IU School of Nursing and the IU Simon Cancer Center, and a board member of the ICC. It's my great pleasure to welcome and introduce today's panel of speakers, of which there are 3, for our final session today. Hope you've enjoyed everything thus far. Our first panelist is Rachel Ress. Rachel is a licensed independent clinical social worker serving as a community navigator for the cancer support community of Washington, D.C. Prior to working at the cancer support community in D.C., Rachel was an oncology social worker with the Lombardi Comprehensive Cancer Center at MedStar Georgetown University Hospital for 3 years. She earned her master's degree in social work at the University of Pennsylvania School of Social Policy and Practice, where she interned at the Thomas Jefferson University Hospital and the Children's Hospital of Philadelphia. Rachel uses an eclectic approach to provide support and compassion to cancer patients and their families, and she is passionate about the intersection of chronic illness and mental health. Our second panelist is Eric Richards, President and CEO of Cancer Support Community Indiana. For more than 20 years, Eric has worked within the nonprofit management and fundraising field in and around Indianapolis. And for more than a decade, he has invested time in cancer-related programming, fundraising, marketing, and strategic planning. His current responsibilities as President and CEO of Cancer Support Community Indiana are to lead all initiatives of the organization, increase brand awareness, oversee fundraising activities, and work with the staff, and Board of Trustees to grow the footprint of the organization around the state of Indiana. He's passionate about helping those with cancer and their families. Eric currently serves on the board of the ICC, Cancer Support Community Global Network Council as the immediate past chair, and is a member of the IU Cancer Center Health Disparities and Advisory Committee. He's also a charter member of the Indianapolis Metropolitan Rotary Club, where he served as president for 2 terms. Eric and his wife, Kristen, have 3 children and currently reside in Zionsville. Our final panelist is Nina Coley. Nina joined the Cancer Support Community Indiana as a community navigator in November 2021. She graduated from Indiana University South Bend with a BS in General Studies. Prior to working for Cancer Support Community, Nina retired from the position of station manager of the new Augusta Post Office Station, which I can attest is the best post office in Indiana. She worked for the United States Postal Service for over 35 years. During her time at the Postal Service, she became a master facilitator and achieved a green belt in Lean Six Sigma, in addition to other meritorious recognitions. In October 2017, she became a breast cancer survivor. After treatment, Nina decided to help others by becoming a peer counselor with the Pink Ribbon Connection and a breast health advocate with the Pink Forever Ending Disparities organizations in Indianapolis. In 2019, she received the More Than a Conqueror Award from Pink Forever Ending Disparities for her volunteer and advocacy contributions. We look forward to your presentations, and I turn the floor to you now.
Thank you, Dr. Rawl. Thank you very much. Appreciate the kind introduction. I'm honored to be joined here with Rachel Ress and Nina Coley, who you heard a little bit about, who will be part of this presentation. We're going to make this very conversational. Please feel free to use the chat function to ask any questions that you may have. But we're going to present for a little bit here. First, I'm going to tell you a little bit more about Cancer Support Community for those who aren't familiar with the work that we do and how it ties into community navigation. And we're thrilled to have Rachel on board, as well as we both of our institutions, organizations are dipping our toes into a new era of program and service and how we interact with those that we serve. So you'll hear more about that as we move forward. But our mission at Cancer Support Community is to ensure that all people impacted by cancer are empowered by knowledge, strengthened by action, and sustained by community, so that no one faces cancer alone. So for more than 22 years now, we have led the charge in Indiana to build a vibrant community of cancer survivors, patients, and their loved ones. And we focus on providing psychosocial support to complement medical treatments in order to nurture every part of the patient as they learn and grow and recover. And obviously with any cancer diagnosis comes feelings of hopelessness and social isolation, especially during a pandemic. And it's our goal to make sure that cancer patient survivors and their family members don't have to go it alone. Our education programs aim to empower people impacted by cancer with the knowledge necessary to take an active role in their fight for recovery. Our wellness programs are designed to strengthen both mind and body over the course of a cancer journey. And our groups and events give our members the support they need to confront cancer. And all of our programs, of course, are provided free of charge, thanks to the generosity of the public and partnerships with health systems throughout the state of Indiana. And that's a little bit about the work that we do. And as we've moved forward through the pandemic specifically, we've obviously had to learn to recreate the wheel, as everyone on this video call has as well. But for us, our bread and butter is really providing that space, that safe space for people to come, to walk through the doors, to be around others who are experiencing the same trials and tribulations they are. And whether it be patients with other patients, survivors with other survivors, caregivers with other caregivers, kids whose parents have a diagnosis with other kids who have parents with a diagnosis. And obviously not able to do that for much of the year for immunocompromised folks. We turned to virtual services in the same manner in which we offer in person. And as we continue to kind of come back in person together, we'll get back to that, hopefully, to that space, that safe space for people to be able to be around others that are facing the same things that they are. But more than 8 years ago, our organization learned and decided that it wasn't enough just to offer a space for people to come. We really needed to determine ways in which we could meet people where they are. And whether that be in a community organization or, as was the case for us, partnering with hospital systems originally throughout central Indiana, to provide the services of support, education, and hope that I mentioned earlier on site within those institutions. So for the last 8 years, we have spanned out across the central Indiana region and partnered with many health systems in many various different ways, trying to help meet the need of the unique populations in which those individual hospitals serve and need. So that's been a really big focus of ours, again, to meet people where they are. As an extension of that, as we've reflected on the work that we do to ensure that we are equitable, that we are inclusive, and that we are making sure that when people do access us or learn about us, that we are keeping DEI principles in mind. And through that review / analysis, we determined that there were many communities and neighborhoods within Indianapolis to start with, where maybe we had not been providing the services needed to the communities in those areas. And so as we've reflected and we planned, we worked with Rachel and other folks out of Washington, D.C. to create what is now called our Community Navigation Program, in which Nina, we're fortunate enough to have Nina managing and overseeing that proposition. And so I'll let her in a few minutes talk more about the specifics of her role. But the vision was to ensure that we had someone, again, that was reaching neighbors and neighborhoods and communities within the community, and which have not been a traditional maybe area of focus for us. And through that, we've learned a lot. We're at the beginning phases of this program, as you heard, that Nina started in November of this past fall. So it's just been about half of a year of getting her feet wet in terms of getting used to her role and really introducing not only herself, but cancer support community to so many communities and individuals within our own community. So that's the genesis of our Community Navigation Program as it relates to cancer support community. I'll turn it over to Rachel to talk a little bit more about what she's doing in the Washington, D.C. area. And then Nina will finish up and talk more specifically about the Community Navigation Program right here in Central Indiana. So Rachel, if I could turn over the microphone to you.
Perfect. Thanks so much, Eric. And thank you everyone for being here and giving us a few minutes to talk about what we know and what we're learning and where we hope to go with this program. I wanted to just start again with what we know, specifically as it relates to navigation, and also, the components of the health equity piece that are so much tied to why navigation is important. From a nationally speaking, we know that Black Americans are disproportionately impacted by cancer with higher mortality than other groups. And that's largely due to barriers that they face when accessing treatment. So to put a number to it and to give some perspective, African American men and women have a 111% and 39% higher risk of dying from prostate cancer and breast cancer, respectively, compared to white counterparts. And more Black people in the US die from cancer than any other racial or ethnic demographic group. So, patient navigation can play a really important role in working to address those barriers, so that we can get people connected to quality treatment, and thus improve survivorship at every stage of diagnosis. So our navigation aim at Cancer Support Community, both in DC and in Indiana and across the country, is really to empower patients as well as their caregivers and their families to manage the social, emotional, practical, and financial barriers to care that exist, so that they're provided with timely access to quality, individualized education, assistance, et cetera, throughout all phases of their cancer experience. In Washington, DC, CSC, Cancer Support Community, along with Whitman Walker Health, which is a federally qualified health center here in DC, and the Jane Bancroft Robinson Foundation, we've been conducting a landscape analysis to really look at the patient navigation support available to specifically Black and African American women diagnosed with cancer who are residents of DC's Ward 7 and Ward 8, which is east of the Anacostia River, and a part of the city that really has historically been underserved. We conducted focus groups and interviews with patients, survivors, caregivers, as well as healthcare professionals and community organizations to really, get a sense for what they felt existed. Did they even know about patient navigation? And what they felt could be improved in order to get that support and those resources to patients. And we heard a lot of things. We learned a lot from those conversations, and the sort of the analysis of those conversations is ongoing, and we hope to have the final results soon. But I can say, from what we've learned so far and from my participation in those conversations, the one thing that we're learning is that the knowledge is not consistent. So some people would tell us that they had never heard of navigation. They didn't know that that was a part of a cancer care team. And they really didn't know how to describe what a navigator should do or what that type of support should look like. Others described really supportive and helpful support from their navigator, and really emphasized how important that role was in supporting them through both, the screening process, diagnosis, and beyond. We also learned that navigation comes from really a variety of sources, not only the healthcare providers and those at the cancer center or their primary care facility, but also from peers and from family members. We had a lot of conversations about folks who, had a church community, and someone in that church community heard about their new diagnosis of cancer, and they said, "Hey, I have been there before. Let me help you through this process. Let me give you some information," and really navigated as a peer-to-peer through that process. The other thing, really, the other sort of final piece that we've really been hearing are about the barriers and the needs, both of patients and of providers. For patients and survivors, the barriers and the needs that we heard sort of time and time again was the need for more mental health support, which we all know, especially given the last few years with COVID, mental health needs are at an all-time high. So that, really sort of just emphasized the need that exists. We also heard a lot about a desire from patients, survivors, and caregivers for more follow-up. They felt sometimes that a navigator would be involved in their care, at diagnosis, to get them to their healthcare provider, to their oncologist, and then that was all they heard from them. That relationship sort of ended once that handoff was made. Interestingly, and not surprising, I'm sure, to a lot of you, the barriers and needs from providers that we heard was really that their caseload was too big. And I can tell you from my time at Georgetown working in an outpatient and inpatient cancer setting, I 100% could relate to what they were sharing. they felt they didn't have enough resources. It was, insufficient, the resources that they did have to support these patients, and that their caseloads were too big. So, just to sort of sum up what we have learned so far, I think, again, the inconsistencies with knowledge about what navigation is, and needing to get out there and sort of talk a little bit about what a navigator can do for both the patient and their caregivers and loved ones. Looking at different avenues and sort of untraditional, if you will, people who may be able to provide that navigation support, whether it be a family member or a peer. And then, of course, there's the barriers and needs that exist in the patient navigation space, as well as the healthcare space. So more to come as far as that analysis, and we're hopeful that sort of what we're finding can inform community navigation in DC specifically. But I will hand it over to Nina at this point to talk about what is going on and what it looks like in Indiana.
Thank you so much, Rachel. Thank you so much. So I'm briefly just going to talk about some of the things that I've been doing out in the community. For me, being the community navigator, I'm pretty much boots on the ground. So if my goal is to reach the underserved and the under-resourced populations in Marion County, Central Indiana region. And the first thing we had to do was, find out where those communities were. And once we targeted those communities, we had to come up with ways in how to reach those communities. So some of the things that we are doing is we are finding organizations that have community boards, like libraries, recreational centers, cafes, even some police substations, health food stores, salons, barbershops. I will spend a few days out of the week, month, going around and talking to those owners, dropping off literature, and just getting some feedback from those locations. Also, I have joined several organizations that target underserved and under-resourced populations. And for example, recently we volunteered to help out at a food distribution location with the Urban League here in Indianapolis, and just continue to build those relationships and have access to those underserved and under-resourced populations. Also, we also have a minority health partnership down here where I've also joined that planning committee. We're going to have a conference in September where we're going to open it up to the community, and it also give me another opportunity to present the programs and services that cancer support community has. What I found when I took the position is that a lot of people, especially in the communities that we're targeting, had no idea cancer support even existed. So the first half of my job is to get our name out there, to get our brand out there, and to be the face of someone and build trust with the communities that they recognize and that they feel comfortable with. I also have several health fairs scheduled. I will be busy this summer, talking to the community, engaging with the community. We'll be at the Black Expo. That's a 3-day event. We're partnershipping with a basketball league, and we'll be there for 6 weeks and sharing information and engaging with those folks that go to the basketball games. So that's going to be really exciting. We're looking forward to that. We also partner with the local and state health department. Our local health department has a prostate mobile unit that will be scheduling to come to our facility because prostate is the #1 cancer for Black males. And we definitely are going to be utilizing that mobile unit for not only here at our local campus, but also in the community. Also, I will be doing presentations with CIONN. That's the Central Indiana Oncology Nurse and Patient Navigators. I'll be doing a presentation with them very soon and doing some on-site visits at the local healthcare facilities to continue to build relationships. We have done several presentations with the local YMCAs with the Live Strong program, just getting the information out and getting our branding out. And then to conclude, we're also looking at some senior living communities where we can target those same under-resourced and underserved individuals. So that's what we're doing so far. I'm super stoked about it. So I'm going to turn it back over to Eric. Thank you.
Thank you so much, Nina. Thank you so much, Rachel. Appreciate both of your insight and for joining me today as we talk to the ICC annual meeting attendees. As you've heard a little bit about the fact that we're at the genesis of what this program can be, what it looks like, and we hope to be able to report back to you once we have more information on what we've learned. Again, I think Rachel hit the nail on the head when she said, really, one of our big goals is for others to be able to emulate what we're doing in their respective communities, whether that be within the state of Indiana or nationally or internationally. So appreciate your time today to join us and hear us to talk about community navigation. So now I think, Mary, unless you tell me otherwise, we'll open it up to questions, but appreciate the opportunity to be here this morning.
Yeah, thank you so much, Eric, Rachel, and Nina. Yeah, if there's any questions, please put them in the Q&A function. Any other comments in the chat? I think we have a few minutes for them to speak. And again, thank you guys so much for joining. I think this is a really great example of how really identifying, looking at the needs of the community, what the data is telling us, and then really finding an innovative way to get there. So I know, again, as you said, it's just in the beginning stages of this program, but I'm very excited to see this and other programs like it in our state. So thank you very much. I'm just going to pause for a moment, see if any questions come in before we move on. Okay, I don't see anything, but thanks so much again to all three of you for joining us. We understand if you have to run, but more than welcome to stay for the rest of the day too. So that kind of wraps up our speakers for the day. And I think we've had a lot of information to digest in a lot of short time. And so I'm very happy to be able to share the recording after so we can go back and watch some of this. But now we're actually going to transition into our yearly anticipated award ceremony. So this time is really time to celebrate the extraordinary accomplishments of our ICC members and our cancer community, our cancer control advocates with this year's awards ceremony. And I think these awards are really, really meaningful because it's not a lot of time that we take to recognize the hard work and effort and impact that we're making in the community. So the ICC really wants to recognize, while this is a small acknowledgement, it's definitely a recognition of the incredible achievements that each of these winners have made in cancer prevention and control in our state. So while I wish we could present these in person, and we'll definitely get all of your awards in the mail, all of these folks have accomplished an incredible amount of things throughout this year and the past. But first, I just want to take an opportunity to go ahead and recognize as well all those folks that joined us in the ICC Employer Gold Standard that you saw this last year. We're proud of those employers who, again, like I've said, have really prioritized and supported cancer prevention and early detection efforts in the workplace. So without further ado, I'd like to go ahead and address our first set of awards. So our first award is our Cancer Control Champion Award, which really focuses on the accomplishments and commitments of Hoosiers over the past year. This year's candidates were nominated by ICC membership and selected by the ICC Advisory Board. Cancer control champions must exhibit leadership in implementing the cancer control plan through ICC work groups, committees, and other cancer control efforts. So I do have bios for all of our winners today, and they are very, very appropriately lengthy, well endowed. So don't mind me if I just do a little bit of trimming to keep moving. But again, we'll have more information about all the amazing accomplishments and careers of everyone today. So without further ado, our first cancer control champion is Lisa Robertson. Lisa is a great partner of the ICC. She's been with the Indiana Immunizations Coalition since 2013 and is a graduate of Hanover College and received her master's degree in public health from IUPUI. She also spent 12 years as director of Reach Out and Read Indiana before coming to the Immunizations Coalition. And she also enjoys reading, watching her kids play sports, her husband coach football, and hanging out with friends. So I'm going to hand it over to Lisa for a few words.
Great. Thank you all so very much. I am honored to receive this award. It always is amazing when you get recognized for the hard work that's been done. I have to recognize my staff because they really are the boots on the ground that get all of the work done that the Indiana Immunization Coalition does every year. So just a few quick highlights from this past year. We launched Project HPV Free, which is our college education initiative. There's a website that you can go to if you're interested in doing education and advocacy for HPV on college campuses. We have the Vax Champs program, which is educating pharmacists and eventually dentists on how to recommend HPV vaccine as cancer prevention. And we also have a maintenance of certification program around HPV, which is a 6 months quality assurance program, as well as tons of educational materials and webinars and resources. And then the other thing that happened about 18 months ago is we went into direct service. And so the coalition has decided, when we saw the rapidly declining rates of HPV vaccination and tetanus and really all childhood vaccines over the pandemic, was that we needed to really become a direct service provider. And so we have started going into schools and communities and food banks and shelters and offering vaccinations on site, trying to reduce barriers around transportation and language and financial barriers for everyone in the state to have access to immunizations. So we'll continue to focus on that, as well as the new hepatitis B universal recommendation for adults. And so that will really give us the opportunity to protect our young adults who haven't had their hepatitis B vaccination against liver cancer in the future. So thank you. I love working with the Cancer Consortium and all of the great partners that we have with you all. So thank you again. I'm super honored.
Thanks so much, Lisa, and congratulations. And I know I say that on behalf of everyone here. It's definitely well deserved. And again, such a great partner, so we appreciate it. I'm going to go ahead and introduce and congratulate our next cancer control champion, Andrea Bauer. So Andrea Bauer is a native Hoosier who resides in Greenwood, has a bachelor's degree in secondary education and a minor in teaching English as a second language from Ball State University. She also has a master's in international relations from the University of Indianapolis and taught ESL for public schools for 15 years. However, her life completely changed 13 years into teaching when she heard the words, "You have cancer." And at the age of 35, she was diagnosed with stage 3 colorectal cancer. Very early on in her diagnosis, she made the decision that good was going to come from the experience, and she searched her local community to find support for colorectal patients, but found none. And so this led her to really research the internet and Facebook, where she found organizations like Colorectal Cancer Alliance, the Colon Cancer Coalition, Colon Cancer Stars, and so on. And she has learned that she needs to be her own advocate and surround herself with people who could help her in this battle. But since becoming involved with the colorectal cancer advocacy world, she's become a member of Never Too Young Advisory Board for Colorectal Cancer Alliance, where she came up with a news media campaign called Blue Boxes, where board members were asked to reach out to their local media and with goal of setting them to cover Colorectal Cancer Awareness Month. Locally, she's worked with Colon Cancer Stars to bring support locally for those impacted by colorectal cancer, run informational booths at the annual Colon Cancer Coalition Get Your Gear Ready 5K, has volunteered with the ICC and the American Cancer Society Cancer Action Network during lobbying time. She really worked to support lowering the colorectal screening age to 45 and has worked with local fire departments to bring awareness to the increased risk of colorectal cancer within the firefighting profession. Most recently, she has worked with the Colorectal Cancer Alliance in Indianapolis to really target and distribute fit kits to marginalized communities. And although much good comes from working with these organizations, the most rewarding part of her volunteering comes from being a patient advocate and resource for others facing the awful disease. So again, I extend my congratulations to Andrea, who I've worked really closely with the past few years, and I yield the floor to you.
Thank you, Mary. So thank you very much for honoring me with this award. And I'm sure a lot of you can relate that we entered this journey as a result of some very personal stories. And so mine was in 2005 when my dad was diagnosed with stage 4 melanoma. And then 8 years after his death, I was diagnosed, like Mary said, with stage 3 colorectal cancer at 35. So the things that I learned was having a support system, strong faith, sometimes sick and twisted sense of humor, and being your own advocate were they're imperative to this fight against cancer. And we all know that cancer rates are staggering, and I'm going to make a shameless plug about colorectal cancer because by 2030, it's projected that colorectal cancer will be the number one cancer-related death in people 20 to 49. This year alone, 3,000 people will be diagnosed, over 3,000 people will be diagnosed with colorectal cancer, and over 1,000 will die from it. And what we know is this disease is preventable, it's treatable, and it's curable if and when it's caught early. So we can and we have to do better. We have to make screening, treatment, and clinical trials available to everyone, no matter their age, their gender, their race, or socioeconomic status. That's really a non-negotiable. And I know I'm kind of preaching to the choir, but really it starts with those of you who are leaders of organizations, committees, and communities. I know from personal experience the tremendous impact that patient stories can have on furthering the missions of your organizations. So I challenge you to find ways to get more patients and more involved. And then as far as I'm concerned, I will continue working on getting patients and survivors and caregivers to tell their stories, to continue telling their stories. And again, just thank you so much. And it's an honor to be part of the Indiana Cancer Consortium. Thank you, Mary.
Thank you so much, Andrea. And again, congratulations. All right, I'm going to switch gears to our final Cancer Control Champion Award, and I'm happy to congratulate Sheila Huck, who is the Director of Oncology Services, Palliative Care, and Breast Cancer at Ascension St. Vincent, Evansville. Sheila received her associate degree in nursing sciences in 1974 from Purdue University and started her career at Wilborn Hospital in Evansville. Shortly after working as a floating nurse, she was transferred to the oncology unit where her love for oncology started, and then began working in the oncology nurse office, mixing and administering cancer chemotherapy to cancer patients. She's volunteered with Evansville American Cancer Society chapter, and through her work through ACS as chair for a professional education committee, support group facilitator for 17 years, and board member. She was also the board president for Evansville Komen Foundation from 2007 to 2010. It was in early 2000 when she was offered a position with St. Mary's Health to start the Community Cancer Resource Center. The Hope Cancer Center Resource Center opened in August of 2001, and that same year she became the Director of Oncology at St. Mary's Health, and then some later years would be known as Ascension St. Vincent, Evansville. She continued her education and earned her doctorate in nursing practice in 2011 from the University of Southern Indiana. Her oncology career has surpassed 46 years, with a tremendous amount of positive change has happened in 4 decades, resulting in millions of cancer patients being cured. And she has led countless successful American College of Surgeons commissions on cancer surveys and national accreditation program for breast cancer center accreditations. She's an advocate for quality care, and Sheila started the Ascension St. Vincent Evansville Palliative Care Program. She currently serves as the president of the board of directors of the Indiana Breast Cancer Awareness Trust, known as the Breast Cancer License Plate Fund. Thanks to Sheila's love of caring for patients, Sheila will retire on April 29th, and she leaves a strong oncology program at Ascension St. Vincent Evansville with wonderful, kind, caring, and knowledgeable staff. So congratulations, Sheila, and I'm going to hand it over to you.
Well, thank you all very, very much. It's very special today to receive this award and from the Indiana Cancer Coalition, as well as hearing all the inspiring speakers today. I think that's what I take home today, is that no matter how old you are and how much you think you know, the speakers we had today were quite enlightening, very informative, and an inspiration to continue the work that I've done over the years, as well as all of you have done, and that there's still so much more work to be done. It's been an honor to work in this Evansville community, both in the tri-state, both in Indiana, Kentucky, and Illinois, as we're located down here. Hearing the speakers reminded me of the programs that we've started, even in the 1980s, that still flourish today, having to meet people where they are. We've had a big focus on serving the underserved. Our mission here is to reach the poor, the sick, and the vulnerable. And we have gone to communities, churches. We've even done breast cancer screenings in a funeral home in our African-American communities, because that's where people had congregated, kind of as a community center, as odd as that would be. But I think that's what's most important, meeting where people are and sharing their stories, building relationships. And that's what this morning has been all about. I could not be more proud of my team here. As I retire next week, we have a wonderful staff of navigators and clinical trials, oncology nurses, social workers, pharmacists, respiratory therapists. It takes all of us as a village to make sure that we have quality care to continue the fight. And to know in my heart today that more people are surviving cancer because of early diagnosis. And that's what's so very important, getting the word out. And it was kind of trampled a little bit these last few years, as we all know from our COVID experience. And those outside of oncology were surprised when I was informed, 2 years ago, we had to close our breast center. We had to shut down everything. And I said, oh my God, do you know what that means? And then what does that mean? I said, all these people are not going to get diagnosed, and they may or may not come back. So it continued to be important to reach out to those folks. I'm very honored today, and I'm very proud of the work that the entire state has done. I'll take a plug here to promote the breast cancer license plate. We're so proud of those funds that reach into almost every county in the state of Indiana for the underserved. I wish sometimes we had different license plates, maybe a colorectal license plate, I mean, it's so nice that we raise money for some cancers and some we leave out, but continue to do the good fight. Thank you so much for this honor. And I appreciate this very, very much.
Congratulations, Sheila. Thank you so much. And I don't think I can say congratulations enough to all today, because it's so well deserved. And we really, really appreciate all the time and effort everyone's put into their work, and a lot of heart and soul. So again, congratulations to all our Cancer Control Champion Award winners. Now we're going to transition to our Outstanding Contribution Awards. Each year, one organization and one individual are chosen. Outstanding Contribution awardees must dedicate their mission and lives to cancer prevention and control, and have major contributions to cancer control in the areas of primary prevention, early detection, treatment, quality of life data, and/or advocacy. So this year's Outstanding Contributions in Cancer Control Individual Award goes to Dr. Gregory Zimmett. Dr. Zimmett is a clinical psychologist and professor of pediatrics at the Division of Adolescent Medicine, Department of Pediatrics at Indiana University School of Medicine, with an appointment in the IU Simon Comprehensive Cancer Center. In addition, he is co-director of the Indiana University, Purdue University, Indianapolis Center for HPV Research. Much of Dr. Zimmett's research over the past 20 plus years has involved the study of HPV vaccine acceptance and refusal, with primary focus on attitudes about vaccination, as well as behavioral and social determinants of HPV vaccination. His studies focus on adolescents and young adults, parents of adolescents, and healthcare providers, and include evaluations of vaccine communication intervention strategies. And in addition to research on HPV, he has also studied cervical cancer screening and has worked with the Indiana Immunization Coalition on educational programs throughout Indiana, giving talks on how clinicians can give effective recommendations for HPV vaccination. Dr. Zimmett served on the steering committee for the Indiana Cancer Consortium from 2011 to 2015 and has served as subject matter experts for several Indiana cancer control plans published by the ICC. So please join me in welcoming Dr. Zimmett.
Thank you very much. It's really a tremendous honor to receive this award. And as others have said, it really isn't, it's an individual honor, but all of our accomplishments are due to our work with others, with organizations and with colleagues. So, I mean, just a few people who I want to mention. Rivienne Shedd-Steele, who I think is on attending the session, has been a great colleague over the past, I don't know how many years, and has helped keep me sane at times. And I have a couple of colleagues currently that I've been working with a lot, Monica Casting and Katie Head, who are both terrific. Lisa and everyone else with the IIC have been amazing, and it's just been great to not just do my research, but actually be able to apply the findings and some of the information we've gathered in practical ways in terms of helping providers do a better job of recommending HPV vaccine. And the ICC as well, that I've been involved with off and on. Anyway, it's been a great career. I had no idea when I started first looking at attitudes about a prospective HPV vaccine in the late 1990s that it would become such a huge part of my academic career. I wish I was sort of out of work in terms of this, that the HPV vaccination rates were high enough that there was no more work to be done. But unfortunately, even though things have improved, we still have, unfortunately, a really long way to go with getting adequate coverage of HPV vaccination. So I'll keep working on it until they put me out of work, which I hope is soon. But thank you again, and thank you to all of my colleagues, and Vicki Champion has been another great colleague. So I can't thank all of these people enough for all the support and help they've given. Thanks.
Thank you so much, Dr. Zimmett. I know we've so appreciated your partnership over the years, and know we can always reach out to you as an expert, and know you'll always come swinging by. So we appreciate it. Our next award is the Outstanding Contributions in Cancer Control Organizational Award. And I'm very happy to nominate the YWCA Greater Lafayette Women's Cancer Program. The YWCA has been nominated because of their tireless efforts supporting women through prevention, early detection, treatment for breast and cervical cancer. And they've managed to grow their Indiana breast and cervical cancer program efforts despite COVID, loss of dollars, and countless other challenges. They've been creative in their approach and keep women's needs at the foremost front of their minds. So with that, I'm honored to welcome Amber Thurman on the YWCA's behalf.
Thank you, Mary. YWCA Greater Lafayette is both honored and humbled to be a cancer control champion in the state of Indiana. Since 1974, YWCA's Women's Cancer Program has nurtured into a regionally recognized breast and cervical cancer screening program. Through partnerships with many organizations, we work together with a unified vision to support cancer control efforts in Central Indiana, with partners such as Indiana Department of Health, specifically YWCA being a grant recipient, serving as the regional office for Central Indiana's Breast and Cervical Cancer Program. Also, relationships with Indiana Breast Cancer Awareness Trust, providing generous funding to allow us to extend our reach into our communities, and numerous medical providers throughout our 36 county service region were able to remove barriers and make preventative screenings accessible to individuals in need. And this work could not have been accomplished without the dedicated staff members who serve as liaisons between program participants and medical providers. So I would just like to recognize my staff, Jill Gard, Valeria Titus, Adriana Cornejo, Corema Chavez, for their contributions towards YWCA Greater Lafayette's success. And I would also like to thank other YWCA staff members who often just pitch in and translate for women in need, and also leadership staff at YWCA for always supporting our efforts. As YWCA's Women's Cancer Program moves forward, we hope to identify new partners who share our vision, allowing us to make screenings even easier to access. We hope to find new ways to collaborate and share resources as we continue our focus on supporting health equity. And thank you again for recognizing our work.
No, thank you so much for joining on your organization's behalf. And again, congratulations to you and all your wonderful team members you mentioned, because it's not easy work and it needs to be done. So we greatly appreciate it. All right, so we are going to next transition into our David Cudwell Survivorship Award, which goes to a cancer survivor who is committed to reducing the burden of cancer in Indiana, exemplifies outstanding leadership, and empowers other cancer survivors and advocates. And this year's award goes to Hope Kaser. I'm so sorry if I pronounced your last name wrong. I should have asked beforehand. But Hope is a lifelong Indiana resident, spent most of her years in Northern Indiana prior to moving to Bloomington. She currently works for the Indiana University Athletics as the Assistant Director for Athletic Dining. In 2019, she was diagnosed with chronic lymphocytic leukemia, and after diagnosis began looking for resources and meetings that were available to her. She made trips to volunteer with Cancer Support Committee at a few events hosted in Indianapolis, and it felt good to talk with others that she knew what she was going through. Within the year, she began having side effects that they found many doctors was due to CLL, and her local oncologist recommended infusion treatment that started in late 2021. At that treatment, she learned of the food insecurity that some cancer patients face and decided she wanted to get more involved. She did research about food resources in the town that were available to cancer patients and caregivers, and share that when she hears someone in need. She currently helps the Cancer Support Committee with the Nutrition for Wellness by getting local Bloomington chefs to represent recipes that are easy for caregivers and her patients to make. And she's also helping the Healthy IU and CSC put together a National Cancer Survivor Day to be held at the Indiana University Memorial Stadium. And just to add on for her nomination, really, they said she was just so instrumental in the development of programs of the expansion of Cancer Support Community. And I think she didn't do herself justice in her bio. So again, congratulations to Hope, and I offer you the floor.
Thank you so much. Can you see me?
Hear you, but not see you.
It says the.
There we go. Now we can see you.
Okay. Thank you so much. So if it wasn't, I'm gonna get emotional. So if it wasn't for all of you and what you do for cancer patients, I don't know where we would be. The resources are great and we need those resources. They're hard to find. So I want to be that champion that goes around and makes sure that anyone who needs assistance has that assistance and knows how to get it. So it's very important for me to be active in what I'm doing here, so that those people who aren't champions for themselves can find the great cancer champions you all are to make the prevention, the groups and all of that happen. I'm so honored to get this, and I'm pleasantly surprised that someone nominated me. So I will continue to do whatever I can do for the cancer patients. And if I can do anything to help any of you, I would be more than happy for you to reach out.
Thank you so much, Hope. No, we truly appreciate, again, like I said, it really it really takes a village, and we all have our role to play. And we so appreciate your sincere help and outreach. Definitely help other survivors, caregivers, patients in the community, because we know it makes a difference. So again, congratulations, Hope, and we appreciate you being here today.
Thank you.
All right, so now we are moving forward to present this year's Indiana Cancer Prevention and Control Policy Champion Award, which I'm very excited to congratulate Danielle Patterson. Danielle Patterson currently serves as the Region Team Lead and the Indiana Government Relations Director for the American Heart Association Midwest Region. As lead advocate, Danielle is responsible for developing the Indiana policy agenda to advocate heart and stroke issues in the Indiana legislature. During her 17 years with AHA, Danielle has successfully advocated and achieved better nutritional standards in Indiana schools, fitness centers to be equipped with an AED and trained staff person, and a statewide smoke-free law, CPR requirement for high school graduation, complete streets ordinances in Evansville and Indianapolis, shared use of school facilities, telephone CPR, Medicaid expansion, self-measured blood pressure coverage Medicaid policy, and postpartum extension for Medicaid recipients. Danielle served in leadership positions with the Cardiovascular and Diabetes Initiative of Indiana, Indiana Campaign for Smoke-Free Air, Tobacco-Free Indiana, Top 10 by 25, and participated on numerous coalitions. In her spare time, she enjoys spending time with her parents, nephew, and 2 dogs. Danielle is a member of the Indianapolis alumni chapter of Delta Sigma Theta Sorority, Inc., board member with Health by Design, and member of the National Black Professional Lobbyists Association. So again, please join me in congratulating and welcoming Danielle.
Thank you. Thank you so much. I appreciate the Indiana Cancer Consortium. I remember when ICC was formed, when I worked at the Department of Health. And I'm just happy to continue to be a partner, especially in the tobacco control efforts. Personally, I really appreciate the work that you're doing. I lost my one and only sibling to breast cancer that progressively turned into liver cancer in a matter of 15 months. And so on behalf of our family, I appreciate the work that you continue to do, especially when it comes to educating minorities. It is so vitally needed and necessary because we lack a lot of times information, resources. We have to teach people how to be better advocates. So if I could continue to use my voice for public health and for the issues that affect all of our organizations, I will continue to do so. So thank you so much. I really appreciate this. You really caught me off guard with this one, but thank you for the recognition and for the award.
Thank you so much, Danielle, and big congratulations again. I know it seems we're catching a few people off guard this year, but I'm happy to do so. I love to recognize people in the hard work. So thank you again for joining us, and congratulations. All right, now we're going to be transitioning to our next award, which is the ICC Sustained Excellence Award. This is a newer award that recognizes organizations that have longstanding contributions to the ICC and notable achievement. And so this year, I'm very excited to congratulate Goshen Health, which has been a great partner for the community and especially the ICC, most notably recently. If you attended our annual meeting last year, we had Rhonda Griffin present about their education and awareness campaigns and success in increasing cancer screenings during a difficult time. So the mission of Goshen Health is to improve the health of communities by providing an innovative, outstanding care and services through exceptional people doing exceptional work. And I'm very excited to introduce Dr. Henry on Goshen Health's behalf.
Thank you, Mary, and thank you to the consortium. Can everyone hear? Okay.
Yes, we can.
Good. So I'm very proud to accept this award on behalf of Goshen Health and the Goshen Center for Cancer Care, and want to recognize our wonderful colleagues up here in our health system, people with great hearts that intend to make a difference in our communities, and they do just that. I want to thank our leadership in the health system too, that afford us the opportunity to do more than just take care of patients during their episodes with cancer, but allow us within this program to perform community outreach, to identify risk populations and behavior modifications that might be necessary, as well as promote cancer screening and survivorship after cancer care. So again, on behalf of our wonderful colleagues, thank you, Mary. Thank you to the Indiana Cancer Consortium. Appreciate it.
Thanks so much, Dr. Henry. And again, I want to congratulate all of our award winners today. Those are the last few that I wanted that we're wrapping up. But again, I wanted to take a moment to again recognize our employer gold standard certified organizations within this past year. So please join me in congratulating Decatur County Memorial Hospital, Hollywood, City of Warsaw, Community Action of Southern Indiana, Instrumental Machine and Development, and Wildman. For anyone wishing to participate in this free recognition program, please visit indianacancer.org on our website for more information. Again, technical assistance is available to help organizations go through this process and really improve the health and wellness of all your employees. And these organizations are also highlighted and recognized for their achievement in our annual booklet. So again, congratulations to all of our award winners. Thank you for our membership who nominated all of our award winners this year. We had some incredible candidates, and meetings like this really give, I feel like, all of us the energy to really keep moving forward and get us excited and invested again. So I appreciate everyone joining today. And now I'm going to hand it back to Dr. Champion for our closing remarks.
Thank you, Mary. I may go off script just a little bit here. It almost tears me up when I see all of the wonderful award winners and the heroes that work every day to eradicate this dreaded disease. It gives me energy, and I hope that this program has given everyone else energy. And you have really done a fantastic job, Mary, of taking a very vibrant in-person program to a very vibrant virtual program. So congratulations for doing that. We hope that everyone will utilize the Indiana Cancer Control Plan. A lot of time and expertise went into developing that for best practices. If all of you are working to decrease our cancer burden here, it'll be a great resource for you. As we mentioned before, please fill out the Employer Gold Standard Initiative if you have an interest. It's on the ICC website. We currently have a grant open that supports this work and closes on April 25th. And we always welcome anything you have to say about how to make us a better organization and how to make our annual day better, hopefully next year. We will be in person, and we'll all be able to be with each other again. Please be sure to complete the evaluation that will be in the chat box and will be sent out later. And those wanting continuing education credits will receive their certification after completing the survey. Again, thank you for joining us, and go out and do the good work. Thank you. Great job, Mary.
Thank you. And thank you for hosting. Thank you, everyone. Appreciate you all as you sign off. Thanks, everyone.
Bye.
Bye.